opportunity to welcome you all here today. Especially, I would like to mention that support she has given our Chief Nursing Officer, Ma'am Nanki Rani. So thank you very much for giving this opportunity to me. And also, I would like to welcome all the guests from outside, especially the RR Hospital, Safdarjung, Calcutta, from Calcutta, Army Hospital, and other hospitals from Rishikesh AIMS, and also the delegates from our hospital. So you all are welcome. Your presence is appreciated. Let me take you through the day. We shall begin our topics, basics of operation theatre, the first one. Second one is anesthesia equipment and drugs used in operation theatre. And the third is ethics and legal aspects, and that is to be taken by the nursing staff working at AIMS. After that, these programs are followed by the intra-operative management of surgeries by the AIMS nursing staff. I hope we have active panel discussions throughout the day. Let's begin the first session for the day, basics of operation theatre. So I would like to call Mr. Navneet to come and join as a speaker, and the panelists. There are 3 panelists. I would direct all the 3 panelists. Mr. Madan, Ms. Shelly, and Madam Subbu Lakshmi. So please take your seats, and also I request to ask questions. If you have any queries, you can ask from the panelists as well as from the speakers. So again, please listen very carefully and you can ask the questions. Thank you.
Is it connected? Working. Shall we begin? Yeah. So good morning to all of you. Myself Navneet Pawar. First of all, I would like to thank, special thank to Dr. Dash. And after that, I would like to thank our CNO ma'am, our DNS ma'am, ANS ma'am, and special thank to Nargis ma'am for giving us such a beautiful opportunity and taking such a beautiful step. So today we are going to discuss a basics and very much important topic, that is basics of operation theatre, the dresses, linens and all. Okay? So shall we begin? Yeah. These are some contents that we are going through today. First of all, we'll talk about the history. Have you ever heard about the word amphitheatron? Amphitheatron was the word derived from the Greek word. It was derived around 70 AD, and that time it was used for some collaboration. Can you see a picture over here? This one. This is a colosseum actually, and there was a lot of people used to come here to enjoyment, for fulfilling their wishes, and there was a lot of fights as well there. They used to have a lot of fun and a lot of gathering here. So that's why it was known as amphitheatron. Next, so operation theatre. You must be knowing about the operation theatre definition. Operation theatre is a place where operations runs. So these are some visualizations of old operation theatre. Can you see it? This one and this one as well. Okay, talking about history and not talking about our ancient history, special Indian history, it will be not a justification, right? So, have you ever heard about the great Saint Sushruta? He was known as and he is known as the father of surgery, especially Indian surgery. He performed a lot of surgeries like cataract surgery, and you must feel very proud that he was the one who founded the nibblers as well. So these are some OT setups. This one, can you see? And this one. What is the difference between these two? The difference between these two is one is actual OT and the another one is a modular OT. This one is a modular OT. It is a replica of actual OT actually. That's why it is known as modular OT. So let's talk about the basics. The first basic one is operation theater is a place where we should make this thing and how we should keep the operation theater. So here it is. Operation should be, there should be no noise, no pollution. There must be safe environment. Like safe environment means like safe from that patient will not fall, patient care, patient safety, that should be very important. The next one is we should rid of from dust, insects or any foreign particles. Can you see these two layouts? One is in right side and another one is in left side. The first layout is from the main building. This one is the older layout, and the another one layout is this one from the new buildings one, new surgical block one layout. So zoning of OTs. What are the zoning of OTs? OTs are divided into various zones, like some clean zones, septic zones, sterile areas and all. So today we will be discussing especially about sterile zone. Can you see this one? Yeah. This is a sterile area where we keep the equipments, sterile equipments. Can you see here? There are a lot of sterile equipments here and here. These are sterile equipments and we should not enter here without any mask, without any proper gowning. We should enter here with gowning and especially with a mask. Next, scrub station. You must be knowing about the scrub station. I will show you the picture first. Here. This is our typical scrub station where we wash our hands, where we perform scrubbing. And here, scrub stations are made up of various kinds, like it could be steel one, stainless steel, it could be metallic, it could be, and different various kind of types we can divide it. Like first here we can see it could be automatic and it could be manual, and this one is both automatic as well as manual. Scrubbing, you must be knowing this one. I will be skipping this part. How to hand wash, I hope you all know this one. Yes, functional consideration, that is the main thing. Where we should made our OT, that is the main thing. Where we should made our OT, it should not be like a noisy place. It should not be a very like crowded place. It should always be on the ground floor, but it's not the mandatory or inevitable things. It's just that we can say it's a suggestion that it should be on the ground floor. Next. We'll be talking today, next part is protocols. Operation protocol. Yeah. What are the protocols? Protocols are the before starting any surgery or operation theater, we should follow some specific protocols. And these specific protocols are first, preparation of patient, preparation for surgeon, hand washing, gowning, gloving, OT sterilization, and management of body spills. First, preparation of patient. First of all, before any surgical procedure, we will welcome the patient and very welcoming environment in our hospital. Before at least it depends, it's not like only that I have written it's here 2 to 3 days. It's not mandatory that you have to arrange the patient before 2 to 3 days. It depends on the type of surgery. Like if it's a local surgery, we can invite the patient on the same day or just before few hours. And if it's a general surgery, or we can say it's a general anesthesia surgery, we can invite the patient on 2-3 days previous, or we can invite some patients before 4 to 6 days as well. And in emergency, we know that patient just came and we will go through the procedure. Next, skin preparation. First of all, skin preparation is like we are doing some surgical procedure. Before doing any surgical procedure or before any incision, we have to make sure that skin should be very sterile. And for maintaining sterility, we use a lot of things like we use a lot of antiseptics and lot of sterile, like we use chlorhexidine, you must be hearing, right? 2% chlorhexidine we use, or we can use betadine 7.5% or we can use the betadine 10%. In our aims, we are using 10% betadine. This you must know. 5 movements are 5 movements, and the right way, correct way of hand washing. Next, gowning. Gowning you must be knowing, and this is the most important thing, because especially in OTs, we made unsterility, especially during gowning. We made a lot of mistakes while gowning. So we have to be very careful while gowning. Next, factors that may influence the number of OTs or running of OTs. There could be, like, it depends on types of surgeries, number of beds, hospital policies, and staff strength. Especially like in some hospitals, there are a lot of staffs, but in some specific areas and some specific hospitals, we don't have such a staff strength. So we get a lot of patient safety care, patient facility that will be reduced. Next, OT fumigation and high level disinfection. Previously we used to do carbonization, you must be knowing, right? Why do we used to call it carbonization? Because we used carbolic acid. Yeah. Nowadays we are not using carbolic acid, and we are using the word high level disinfection. And OT fumigation, these two are some fumigators. One is this side and one is this side. And here is I think in our aims we are using Eco Shield for high level disinfection. What is the Eco Shield made up of? Anybody knows? Yes? Yeah, correct, exactly. H2O2, right? Yes. And yes. Next, we'll be taking new topic, and the new topic is OT dresses. OT drapes and dresses. So OT drapes, what are the OT drapes? OT drapes are some clothing that we should put over the patient and on the patient. That is OT drapes. OT drapes are made up of various kind of materials, like it could be a fabric one, it could be cotton one, it could be a different types of things. Types of linen. Mostly in our OTs we'll be using 2 types of linens, and one will be cotton linens, 100% made up of cotton linens, and the another one is a disposable one. Disposable one mostly are formed with fabric one. So can you see one this side and one this side? Which one is this? Cotton, simple. And which one is this one? Disposable, yeah. These two are different types of drapes. Can you see this one? These two are cotton drapes. And here we have disposable drapes. Like this, can you see these boxes here? These packets? Yeah, these packets, here we packs like these drapes, we keep it like this. What are the purpose of drapes? The first and main purpose of the drapes is to make the sterility. That is the main and important thing. And the another one is isolate the patient, or not the patient, but isolate the surgical part where we're going to perform the surgery. That is the main thing. Next, there are some various type of drapes, like we use AS, we use OPTs, like it are called different names. Like OPT, here in AIMS we use OPTs, but in Milhans, in JIPMER we use just green sheet, sterile drip, like that we use. So these are of different size. Here OT dresses. OT dresses, you must be knowing, you must be having lot of things that we want this color OT dress, that color OT dress, correct? So here in AIMS, our AIMS, we use green color OT dresses, and mostly all over India we use green color or blue color OT dresses. So but we can use and we can choose various colors of OT dresses. And for patients as well, you must be knowing, here, can you see the uncle? Yeah, he is enjoying his OT dress, and these two ladies and gentlemen. So finally, at the glance, I will show you some videos. This was from cadaver patient actually. Am I audible? Yeah, this was from cadaver patient. He was donating his organ. And the second one is from neurosurgery. And this one from liver transplant. So, because we don't have so much time, so I would like to wrap up my topic here, and I hope you will enjoy it, and please read this and go forward, and have a great day. Yes. If anybody is having any questions, you can raise it, and remaining, yes, please ma'am.
Topic is very good, but the thing is, talking about the OT dress, the importance of the OT dress, why we are wearing the OT dress instead of wearing our product. Going to a very vast topic, I know that, but this is very important why we are wearing the OT dress inside the OT. Actually, I introduced myself, I'm coming from neuro OT. So it is important because we, the health carrier, we are the carrier of the, sorry. We are the carrier of the.
Excuse me, just let us thank him first,
Yeah, yeah.
and then we'll have the question from the audience.
Yeah.
Say one.
I think that is not on. Yeah.
Thank you for beautifully covering this topic. You have covered all the aspect very holistically, from the time of entering into the OT to the how it need to be built, and how sterile item need to be kept, and how the drapings, how we need to send them to the CSSD for sterilization. And thank you so much for enriching ourselves.
Thank you, Navneet, for the session. You are very spectacularly covered the whole topic about the operation theatre. Thank you.
Navneet, thank
Yeah,
you.
ma'am.
That's a wonderful presentation. It's very comprehensive. Can you just tell us, when do we go for this OT drapes you were talking about, the cotton one and the disposable?
The
Is there any
disposable.
specifics that you go for, these situations you have to go for the disposable? Is there anything?
Yeah, ma'am.
Can you just tell us?
Yes, definitely. Because like disposable drapes, they are very expensive, and we cannot put everything on the patient's head. So that's why we go for the cotton, because they are reusable one. So we can go through. That's why we are using reusable one or cotton one. But in the case of sterility, if we are talking about sterility, both researchers shows that both are equally verified, that they both are equally acceptable for the sterility. Ma'am.
Thank you. We have questions from the audience. Yeah, you were asking something. Yeah. Please introduce yourself.
My name is John, and I'm coming from Neuro OT AIMS.
Neuro OT, okay.
So I would like to just highlight that the importance of wearing this OT dress. I think because of maybe the time consuming, he did not
This topic
mention.
is on drapes only.
Yeah, drapes only.
Yeah.
But it mentioned, the drapes. We are using in our OT. We are using only this disposable as we are touching in the brain itself. So to prevent the infection, so we are using mostly this disposable, because the linen has some particular microparticular. It's like traveling through the air. So to minimize the infection, because of the sometimes these days we are facing the surgical site infection also these days, but that is resoluting this day. So I think it's important using, even though maybe some of the patient might not be afford, but it's important for using this disposable one, because it's prevent more the infection than the linen one that I want to highlight. That's
Are there any studies that prove that it
yeah, we
has,
do lots of like QI studies, but this day I think we are doing no more because of the
So you have
particulars.
a QA study that supports this?
Not much, but we are doing it inside only, because we are like how much we are using, and then how much we are using this disposable, and then the linen one. But we are in ourselves, because
Yeah.
general surgery and neuro, we
Yeah,
cannot,
that's what,
we
Mr.
cannot
Navneet
compare.
was saying.
Yeah, but it is a very good topic, and even me, I'm coming from neuro OT, but the topic is very good and very experiencing moment. Thank you so much.
Thank you. So that is what Mr. Navneet was saying, right? Depends upon what surgery that we are going for, right? Because she's from neuro OT, we know neuro, inside how important it is that it has to be kept so sterile. Then we go for drapes. It not necessarily the same for other surgeries, as you were saying. Thank you, Mr. Navneet.
Okay.
I would like to add on it, every disposable and the linen, whatever we are using, everything has a drawback and the benefits. If we are using a linen, there might be infection if it gets wet. So if disposable we are using, it is financially, economically it is very expensive, and it also create a more trash to dispose of. So both the things, we have to think about all the things, economically what is better and what we can provide, and biomedical hazards we should see also. And the other thing is, whenever we feel like that we have a rainy season, the linen usually doesn't comes in time, so that is an option to use a disposable drapes. And what else, anything else anybody wants to add on it, you are please welcome, otherwise we will close this session. And thank you all the panelists, Ms. Shubhalakshmi, Madan and Shelly, and especially the speaker, Mr. Navneet. He took a very good stand for all and he showed everything, old OT, new OT, hand hygiene, surgical scrub, and what kind of OT we should have, and patient safety and staff safety in the OT. So that is very knowledgeable for us, and I think we updated our knowledge about the operation theatre. One thing also I forgot, that we have to maintain a uniformity. That is why we use OT dress. So no one can enter that OT, otherwise it will look like we are somewhere else in the market. Or so OT dress is very, very important, and it also restricts the infection in the OT. So thank you very much once again.
Thank
And
you.
I would like, you can add on. He
Okay.
also wants to add on
Yeah.
something.
Ma'am, like I have told that it depends on types of OTs. I have worked in NIMHANS for neurosurgery as well for 5 years. So in neurosurgery, there are a lot of chances to get the infection, especially for meningitis. But in other OTs like ENT, we don't take such a specific form, because in neurosurgery, yeah, there are chances of this thing for infection getting. That is the main thing. That's why we are getting this question, right? Yeah. Thank you so much, and have a great day ahead. Thank you.
Navneet, please stay there. We are going to felicitate, and I'll call Ms. Sunaina and Mr. Sonu to please felicitate with the token of appreciation.
Madan sir.
Ma'am Shubhalakshmi, please come. Madan, please come. Both of them. Thank you, Shubhalakshmi. Now we are going to start our next topic, an overview of anesthesia equipment and anesthetic drugs. So here I would like to call Mr. Shanmugh Rajna. Please come. Dr. Akhil, anesthetist. He has not reached yet. Mr. Kanishk Yadav, nursing officer, as panelist, and Mr. Trilok, nursing officer.
Namaskaram everyone, I am Rajana Sharmukrao from Main OT and I am working as Operation Theatre Technologist in AIMS. So let us dive into today's topic, which is Operation Theatre Preparation and Anesthesia point of view. So the word anesthesia, like when we come into anesthesia, the main thing we need to remember in our brain is it is always patient specific. It differs from each and every patient and it differs for every surgery. So that is the first point we need to remember in anesthesia. And the second point we need to remember in anesthesia is be ready for the worst situation possible. The thing is that be ready for the worst situation possible, because we cannot expect that everything will go in a very nice flow every time. So inside OT, especially in anesthesia point of view, like we always encounter some or the other issues with the patient. So it's better we be ready for the worst situation possible. We don't know when patient goes into arrest, like when we need to revive. So there are many such kind of conditions. So better be ready for the worst situations possible. So in anesthesia these days, we follow a term called balanced anesthesia. It's nowhere anesthesia now. It's like balanced anesthesia is nothing but in which we are giving adequate depth of anesthesia to perform surgeries, and along with that we are taking care of hemodynamic stability of patient also. So in this thing we use inhalational agents along with some opioids, along with that some muscle relaxants also. It's like a combined effort of all these things. It's not just if I give some propofol or something, let the patient sleep. This is not going to happen nowadays. That is why it is called as balanced anesthesia. It's nowhere called as anesthesia nowadays. So in anesthesia especially we have anxiolytics and amnesia drugs and analgesic drugs as well as sedatives. So all these are included within this anesthesia thing. And along with that, like we will be using some ET intubation devices and some of the other monitoring devices, as well as some of LMAs in case of some emergencies. And along with that, we sometimes use regional anesthesia also. There are two types of anesthesia, which is nothing but general and regional anesthesia. And regional anesthesia is mainly like central blocks. Like mainly central blocks. We have some other kind of blocks also, but still mainly these are central blocks. And the point is like we can use regional and general anesthesia together also. And always we need to remember, like if we give regional anesthesia, we can sit aside happily. It's not going to happen. Even in some cases of regional anesthesia, it doesn't work as we expect. Sometimes we need to convert regional anesthesia into general anesthesia suddenly. So for that reason, as the first sentence I said, be ready for the worst situation possible. So next, when an operation theatre technician or technologist or anesthesia technologist, when we enter into the OT, what we usually do and how we usually think. I just want to let you know all these things. So whenever we enter into the OT, first of all we go into OT and we will see case list. What is the case list and parameters of patient, whether patient is child or neonate or adult, such kind of divisions. And after that we will go and do our hand scrub for hand hygiene maintenance, and after that we will come to our anesthesia machine, and then we will go to see these resuscitation devices, whether resuscitation devices are there or not within the OT. If they are not present, where are they? Like in main OT we have 12 OTs, 12 number of OTs, but we have only 3 defibrillators with us because of some reasons. So we need to find where the defibrillator is, whether it is in working condition or not, whether it works with and without battery backup or not, and we need to see all other devices which are accessories for the defibrillator available or not, whether disposable paddles are there or not, and whether it is accessible for pediatric patients or not. All these conditions we need to vary. So first thing is defibrillator, and second thing we observe is ambu bag, whether ambu bag is available or not. If it is available, whether it is working or not, because most of the times we don't use ambu bag these days. Like most oftenly we don't use. We use but not oftenly. So we will keep in a drawer after sterilization, and the thing is that we will open it after a so long time, and suddenly we want it to work. The thing is that sometimes it is just a bag. It is just a bag, it can puncture at any time. So better every day we need to check whether ambu bag is functional or not. And next we go to Bain circuit. The thing is that why we need Bain circuit is, see, anesthesia workstation, we don't call it as anesthesia machine anymore, it is anesthesia workstation. So whenever we see the anesthesia workstation, like it is a mixture of components, it's like both gaseous as well as electronic made. The thing is that we can't always rely on some electronic or gaseous things. They can they go into such kind of conditions that they won't work anymore at some point of time. Even after connecting it on patient, sometimes there are many conditions like machine got failure. So machines will be failed and we need to search for some other route, right? So that other route is nothing but Bain circuit. At that point of time, we will deliver at least fresh oxygen to the patient by using this Bain circuit. And next, the other thing is Jackson-Rees circuit. It also have the same work as Bain circuit only, but in pediatrics and neonates. So, and next, we will go for oxygen cylinder supply also, like whether oxygen cylinder supply is proper or not, whether pipeline system is working or not, and index system is working or not, and whether we have connected proper oxygen into the proper socket of machine or not. So such kind of things we will see, and whether it has any leakages or whether it is full or half or it is emptied, such kind of things we will observe first of all after entering into the OT. It's not that directly we will go into the machine and we will check machine and we will say yes, today we are ready for the case, anesthetist sir please take the case. We are not going to say like this because we need to see all these things. And next, and the last thing you can see, like I'm sorry to say, I have seen many times inside our OTs only, like no one is following these things. So for that reason I placed this. Oxygen cylinder safety. No one is following oxygen cylinder safety. Like we need to make sure that oxygen cylinder safety is there because they are just cylinders. They can explode at any time, and moreover, oxygen is highly inflammable. So better remember. We need to remember it. Like it can explode at any time. So let us move into next thing. And here are some mnemonics. See, what we do as an anesthesia technologist, like in what way we think step by step. So that mnemonics is nothing but MS made. MS made, which is nothing but first M stands for machine check. The thing is that machine check, and next is like whether suction is working or not, and next M stands for monitors, and next A stands for airway equipment, and IV access, I for IV access, and D for drugs, which includes both anesthetic and emergency drugs. So this is just a mnemonic just to make everyone remember like what stages involve in checking machine. So the thing is that here you can see I have kept some diagram which is showing Doraemon. I hope everyone know Doraemon. The thing is that we as anesthesia technologists as well as surgical technologists as well as nurses, we are nothing but we are Doraemons having magical pockets for surgeons and anesthetists. So for depicting that I have kept this message. I mean, the thing is that whenever they want something, yes, technician ji kaha hai? I'm like, yeah, yes sir, I'll give you, just wait. So for that reason I have depicted that we are just Doraemons here. Fine. So usually we have a machine check. First thing is that in MS mates I have said M stands for, first M stands for machine check, right? In machine check we usually follow 14 steps. This is like 14 step stages usually previously we used to use for older machines, not newer machines, because in newer machines everything is automated. Fine. Even machine checks by its own, it is nothing but self-test. Machine checks on its own whether if there is any discrepancy, it will let us know like there is some oxygen leak or there is some nitrous malfunction or there is some electronic malfunction or some valve malfunction. So all these things will be said by machine itself these days. But the thing is that like every anesthesia technician need to know these 14 things. The thing is that I am not going deep into these 14 steps because this is more technical and even not useful for most of you. So for that, I mean, if you are interested, you can go through that. I am not saying like you can't, but the thing is that this is not the time for this. So for that reason, these 14 steps I will skip. The thing is that I just want to show some figures for you. For that reason, I include this in this presentation. Thing is that The thing is that here we have three systems. Within anesthesia workstation, we have three systems. One is, you can see at top end, that is high pressure system, intermediate pressure system, and low pressure system. Here we have three kinds of systems. The thing is that, see, in oxygen cylinder, I think most of you know the pressure will be 2200 psi when it is completely filled. If it is completely filled, it will be 2200 psi. Thing is that it's like much more than our home gas cylinder. So the thing is that at that pressure, if we give oxygen to a patient, you just think what could happen. So for that reason, we need to regulate at each and every stage that pressure we need to regulate. You may ask, why don't we supply direct low pressure system from a manifold? The thing is that if you flow that in that low flow system, it won't reach from manifold to your OT. Manifold is in our ground floor and our OT is in 8th floor. It won't reach till that. So we need that pressure for that. And with that pressure only we can store more amount of oxygen too inside a cylinder. And one more thing, after this, like here you can see two types of cylinders as of now, but we can depict any kind of cylinder there. So only I have mentioned clearly high pressure system, where nitrous cylinder supply and oxygen supply here you can see, and you can keep many cylinders like Antonox, such kind of things, but the thing is that most commonly used are nitrous and oxygen as of now. And after this, here you can see cylinder pressure gauge, first cylinder pressure gauge, there you can see. And so these things are like, these are decreasing the cylinder pressure from 2200 psi to some hundreds. It is coming to hundreds. It is decreasing the pressure there. So these valves are there, these gauges are there to regulate that system. And after that, we will be giving it to intermediate pressure system. So in that intermediate pressure system, we have fail-safe valves. The thing is that we have to know, like at every point of time, whether our safety is being breached or not. Our safety should never be breached. We need to make sure of that. For that reason, we have valves and these pressure gauges at every point of our mission. And after that, we have oxygen supply alarm. Alarm is the thing like, see, here I have connected our ventilator to patient, and after that I don't see into monitors for suppose, for some reason. And after that, if oxygen got cut off, so patient is not inhaling oxygen, what could happen? Immediate hypoxia may lead to cardiac arrest. So such kind of things might happen. For that reason, we need to have oxygen safety valves also. At every point of time, it will announce you ki patient is going into apnea because of no oxygen supply. So we can rectify it immediately. For that reason, we have these safety valves. And after that, we have a low pressure system in which we have flow meters as well as vaporizers. Vaporizers are nothing but through which we are giving our inhalational agents to the patient. So there also you can see we have few more valves called flow control valves and oxygen flush valves, such kind of things we have. And at final point, can you see machine outlet, where common gas outlet, at that point of time our pressure of oxygen or nitrous or whatever gas is going to the patient will be 5 to 8 psi. So from where we came to where, like we came from 2200 psi to 5 to 8 psi. So the thing is that we are reducing it from high pressure to low pressure so that there won't be any disturbances for patient to inhale it. So and here you can see first step will be verify backup ventilation equipment is available and functioning or not. Backup ventilation system is nothing but like ambu bag and brain circuit and such kind of things. If mission goes off, at least we can use ambu and these mechanical things we can use at least if something goes wrong with electronic thing. And after that, check oxygen cylinder supply. And after that, see, the thing is that we might be thinking yesterday only I have changed the oxygen cylinder, or just now I have changed the oxygen cylinder, new oxygen cylinder I have just placed it, it would be filled. We will be thinking like that, but you should never believe on that. You just open the oxygen cylinder and check for the pressure whether it is full or not. At least it should be half of the oxygen cylinder. Fine. And after that, close the cylinder. Don't forget to close the cylinder because it will be drained out. It will be drained out. And after that, check central pipeline supplies, whether they are working or not, and whether they are delivering adequate amount of PSI or not. And after that, we will be having initial status for low pressure system and perform leak check. perform leak check at every point of time, because see, at every point of time we have many kinds of leaks which might be involved in circuit level, or which might be in anesthesia workstation level, or it might be at patient level. So we need to be always careful about where we have leaks. The thing is that wherever we find leak, we need to rectify it immediately, because we are providing inhalational agents along with fresh oxygen and nitrous also, so which might pollute the operation theater if we have leaks in the machine or circuit. For that reason, we need to be more careful about leaks. And adequate amount of inhalation agents and fresh gas flow might not be there to patient if there are leaks also. Even that might cause issue to patient as well as staff inside the OT. For that reason, better twice or thrice check for leaks. And after that, turn on the machine. Till now we did not turn on the machine. These are all mechanical components only. After that, at 7th step, we have turned on the machine, and we will test flow meters, whether flow meters are working or not, bobbin is going up or not, whether it has any breakages or not. So all these things we will be checking, and after that we will be going for scavenging system. In scavenging system, we need to check whether scavenging system is working or not, and whether we have added AGSS system, and as well as whether we have included some soda lime, whether which is exhausted or which is in working condition or not. For that reason, we will see for color changes. And after that, we will calibrate oxygen monitor. We will have oxygen, different types of monitors, whether at 21% of oxygen or not, whether machine is calibrating it or not, such kind of things. And after that, we will check initial breathing status and perform leak check. And after that, test ventilation systems. Later on, we will check, calibrate all the monitors. This is a multi-para monitor in which we will be checking all kinds of monitoring devices, non-invasive as of now. Invasive I will discuss later on. Non-invasive will be like a temperature probe, NIBP monitor, and SpO2 probe, and ECG cable, power cable, and earth cable, all these things. We need to check them. It's not that I just placed all these cables, you'll be assuming they'll be working. It's not like that. This is mission check. For that reason, we need to check our monitors also, whether they're in working condition or not. We need to keep that pulse ox probe on our thumb, whether it is working or not. In the same way, we need to hold the ECG electrodes, whether it is showing some kind of graphs or not. We need to check all these things. And BP cuff, whether it is inflating or not, whether it is working or not. The thing is that sometimes when we place BP cuff on patient, sometimes what happens is cuff won't get inflated, and so that would be like wasting of time inside the OT. For that reason, we need to check before all these things, before patient comes. And by the end of these all steps, at final status of the machine will be all vaporizers are off, because we switched on vaporizers for checking leak test. For that reason, we need to switch off the vaporizers, and APL valve should be open, and selector switch to be on bag mode, because when patient comes, we will be we will be doing bag and mask ventilation for the patient. So all flow meters are, whether they are in zero or not, because oxygen flows might be wasted. For that reason, whether they are in zero or not, and nitrous might be wasted. For that reason, we need to check it, and patient suction level is working or not. See, next point is like, as I already said, MS made is the mnemonic. As first point is mission check, and second point is suction is working or not. Usually we maintain suction between minus 250 mm Hg to 400 mm Hg. The thing is that most of our OTs, suction machines, those pressure gauge won't be working. So how we will find whether suction is adequate or not? Suction will be working, we will be getting suction, but whether suction is working or not, how will be knowing? The thing is that there is a small cheat code for that. Just off the suction tube with your thumb and place it at your waist level, and just leave all your fingers, whether it is able to, whether it is capable to hold up or not. That thing we need to observe. If it is holding, yes, pressure is enough. If it is not holding, we need to check for some leaks and everything. We need to make it adequate. We need adequate suction. And after that, this is our dragger machine which we are using. Here are the components, I can say, like there in the point A, you can see that is our ventilator monitor. And after that, we have some oxygen flush valves, and we have vaporizers. there, and we have oxygen outlet, extra oxygen outlet, also auxiliary oxygen. So in case of mission failure, we can use that. And there you can see eye point, at eye point you can see soda lime, which I said in scavenging systems. And after that, when you see into ventilator monitor which we use, we have different parameters which we will be seeing: flow and volume, and anesthesia gas pressures, and carbon dioxide concentration, ATCO2 concentration, whether it is adequate or not. And after that, MS made. Okay, next thing is that airway equipment. In airway equipment, we will be having Goodell's airways, which will be selecting according to age of the patient and build. And here one thing you can observe, like even in your ICUs and such kind of things, you might be needing a Goodell's airway. So adequate, proper size of, appropriate size of Goodell's airway, how will you select is, check for the tip of the patient to the tragus of the patient length plus 1 centimeter. That should be the length of your Goodell's airway. And you can use nasal airways also. So here you can see the different color codings of airways which we use, and the upper one is nasopharyngeal airway and lower one is Goodell's airway. It is just to create a gap between our pharynx and tongue to prevent our tongue fall. The thing is that once we give anesthesia agents, what happens is patient tongue might fall back, and which may occlude the airway. So for that reason we are using Goodell's airway. And after that, as I already said, we will be doing bag mask ventilation. We will be using these masks, different sizes of masks according to patient. As I already said, anesthesia is all about patient specific things. And after that, we use different kinds of laryngoscopes according to patients. Sometimes we will be needing normal laryngoscopes, which has Macintosh and Miller's blades. Sometimes we will be needing some video laryngoscopes. Sometimes we will be needing fiber optic bronchoscopes according to conditions of the patients. And after that, we will be having some supraglottic equipment like LMAs, different types of LMAs, usually AMBU and Procil LMAs, to be placed if we are not able to insert tubes, ET tubes. So at that point of time, we will be using them, and we will be selecting them according to weights of the patient. There you can see the table, like according to the weight, you will be selecting the LMA, and according to it, you will be filling the air into that. And after that, infraglottic devices include ET tubes, as we already know, every one of us know, most of us know. And some of the infraglottic devices, like other kinds of ET tubes, there are many kinds of ET tubes which include RAE tubes, flexometallic tubes, MLT, MLS, microlaryngeal tubes, and double lumen tubes, DLT tubes. And emergency tracheostomy should be ready in case of any difficult airway conditions. So it is like our backup. It should be backup for any difficult cases, difficult intubation cases. So here you can see, like needle cricothyrotomy, we will be using cricothyroid membrane. We will be using a cannula of 12 to 14 gauge, and we will be inserting it in cricothyroid membrane, and we will be giving jet ventilation. The first image which you are seeing is nothing but jet ventilation device, through which we can flush the oxygen rapidly into the patient. Otherwise, as we already know, tracheostomy, emergency tracheostomy. And after that, some of the important pictures, just you see, like we will be using bougie and stillet. There are some differences between bougie and stillet. Stillet is used to introduce the tube into particular location. The thing is that posteriorly we have esophagus, and anteriorly we have trachea. The thing is that sometimes when we try to intubate the patient, what happens is, after placing laryngoscope, this tube will be pushing posteriorly. The thing is that if it goes posteriorly, it will become esophageal intubation. It's never going to become tracheal intubation. So especially in GI surgeries, it will be very problematic if we do esophageal intubation, because there we have gastric juices. Most of the cases, some of the cases will be like obstruction cases in GI. So we already have some gastric juices inside the stomach, and we are intubating into the stomach, and we are flushing all our gases into the stomach. What happens is aspiration. There will be chances of aspiration later on, and moreover, patient won't get any kind of oxygen into him. So for that reason, we need to take care of that, and there we are using stillet. And bougie is such a kind of thing, like it is malleable, and at some points of time we can use bougie even to supply fresh gas flow to the patient where we can't introduce ET tube at that point of time, and even exchanging, it can be used as an exchanging catheter for intubation. Like ET tubes can be like, we can take out the ET tube and we can
Shanmuga,
place one more.
I think we can wind up
Yes, sir.
quickly.
And these are different kinds of ET tubes, and these are different kinds of connectors which we use inside OT. And complications, especially in JA surgery, mostly include pulmonary functions will be impaired, might be impaired, it not will be, might be impaired, because in abdominal surgeries most of the time we will be seeing pulmonary functions risks. And after that, heat loss, mainly heat loss can be done through like radiation, conduction and evaporation. Such kind of things we will be avoiding by using warm fluids and warm irrigation fluids, as well as placing some warmers upon the patient. And laparoscopic surgeries, in tab block we will be giving, like if a patient we can't give epidural or spinal, at that point of time we will be giving tab block at the end of the surgeries, because we need to decrease opioid usage post-operatively. So invasive monitoring includes arterial and central venous thing, the CVP, those kind of things, because we need beat to beat arterial monitoring in JA surgeries especially. And when we come to anesthesia drugs, it will be like anesthesia triad, as I already said, hypnosis, analgesia and muscular relaxation. Yeah. So here you can see in balanced anesthesia we will be using induction agents, analgesics, neuromuscular blocking agents, and inhalational anesthetics and local anesthetics. Here one point we need to remember is in neuromuscular blocking agents, we need to remember in JA surgery whether there is any hepatic issue or hepatic complications or not. If there are any hepatic complications or hepatic resections, we should not use few of the muscle relaxants, as they are getting degraded in liver especially. So at that point of time we will be using especially atracurium and cisatracurium, and some of the sedatives, antiemetics and adjuvants. And reversal agents, as we already know, like glycopyrrolate and along with the neostigmine. Actually, reversal agent is neostigmine we will be giving.
I am going to have to stop you now.
Yes, sir.
Okay. How many slides do you have left?
Done, sir.
Okay,
Fine.
excellent. Chalo. Well done. A very comprehensive presentation. Okay. A couple of points I'd like to make is that I came a little late. I'm sorry about that. But the leak check. Ideally, a leak check should be done after every case. Okay. And this is true more so if you are changing the circuit. Every time you change a circuit, you do a leak check. Okay, because there is always a chance that there might be a defect in the circuit itself. Even though it's a new circuit, you might encounter a leak. So always better to do a leak check between cases. Okay, before the start of the OT, in the morning, and after every case you do a leak check. Soda lime canister, especially in our setting, we have, I don't know what kind of manufacturers we have these days. So soda lime is getting exhausted very quickly these days. So always keep an eye on the IMCO2. ETCO2 ke niche there is a smaller number, the IMCO2. Ideally it should be 0 or less than 1. 1 or less than 1. If it's more than 1, you can always ask the resident or the consultant in the OT, do we need to change the soda lime canister? Okay, and be ready for that. Excellent presentation. What I would suggest is, Shanmuga, you can share this presentation with your colleagues. So everyone has phones these days. This is sort of a ready reckoner for everyone. ET tube sizes, oral airway sizes, everything. Okay. So in case you have any doubt between cases, preparing for the next case, you can just go through it quickly. Always a very good idea to, if it's a difficult case, especially a difficult airway, always have a discussion with the anesthesia team, as in what are they going to require, because many a times you need the fiber optic, the LMA, the glide scope or the CMAC. So it's always good to have it ready inside the OT before the case actually begins. And इससे पहले कि resident कहे कि भाई मैंने तो बोला था आप लेके नहीं आए, you always preempt that. Okay, make sure that you have everything ready at your place. Okay, any questions for Shanmuga or for us?
The
This is
topic
all,
itself is a
this
very
all
vast.
about teamwork. Whenever we are entering the patient side OT, whether the technician or nursing staff, we just go through this, all the checklist. This is
Yes,
good.
sir. Yes, sir.
Yeah, na? Thank you, Mr. Rao.
Thank you, sir. Thank you, sir.
I appreciate your effort. The topic itself is a very vast, we all know. But the time limit was only
I understand,
20
sir, but
minutes.
actual में I was informed कि 30 I have 30 minutes.
As Dr. Akhil said, try to share your slides with everyone.
Thank
na?
you very
Thank you,
much.
sir. Thank you so much. Thank you. Thank you, everyone.
Dr. Akhil, I would like to welcome also and thank you also for sharing your experience and important points about the anesthesia drugs and the equipments. And I want you to stay there. I call upon my DNS to please felicitate Dr. Akhil and all the panelists as well as the speaker. So please welcome. And I will also call Isabella. Please come forward. Isabella, OT in charge of GI surgery. And Mr. Trilok. And Mr. Kanishk, please. कोई बात नहीं. Thank you very much, everyone, and I hope you all knew about the questions. And if any queries you have another, then you can ask. Otherwise, we are going to close this session. Thank you very much. We are going to start our next session, that is ethics and legal aspects of nursing. So I'll call upon Ms. Arpana, the nursing officer from AIMS, and the panelists are Ms. Vasundhara, senior nursing officer, surgical block, and Deepak Soni from main OT. We are already running shortage of time because of little bit a long session. So we will start early, and I request her to complete it fast, finish it fast.
Thank you, ma'am.
Deepak Soni ma'am. Yeah, ma'am. And you?
So good afternoon, everyone. My name is Arpana Masi, and currently I am posted in NCA block as a nursing in service educator. And all of you are from OT. I hope all of you are from OT, working nurses working in OT. So most of you are from OT only. So I have also a vast experience of OT. Only from January I've been working in ward side, but my heart is always in OT, and I love to work in OT. So I always call myself as an OT nurse. So today we will see the ethics and legal aspects of nursing, especially working in the operation room. So as you all know, and as you all have the experience of working in operation room, you all know that it is a fast-paced, a critical environment that you work, and so that you may come across and encounter some ethical issues while working in OT. And at times you come across life-threatening conditions and events that require immediate actions and attentions. So the OT nurses are always exposed to certain challenges. Now, since my time is cut short, so I'll be running fast and I'll deal with the practical aspects more regarding the OT. So, some definitions like ethics. Ethics are the rules of human conduct. Basically, these are the set of rules that are formed so we may function according to that rules. And morals are principles on which judgment is based, what is wrong and what is right. So what are the purpose of these ethics? So first of all, to maintain the minimum standard of nursing. So if we function below those standards, then we may fall under legal implications. So that is why these ethics are formed. Second, it provides it provides a basis for the regulatory bodies to give their decision. So हमारी regulatory body कौन है? Which is our regulatory body for nurses? INC, okay, Indian Nursing Council is our regulatory body. So, and the third and the most important is the ethics. We should follow the ethics, and these are ethical principles are made so that we can safeguard ourselves and as well as the patients also. Now we have these 6 ethical principles you all must have studied in your nursing courses. So first is the autonomy. Autonomy is the right to make one own's decision. Okay, so the patient is there in your OT or pre-operatively, like consent is taken. So we cannot force or impose our decisions on the patient. Patient has a right to refuse the treatment, accept the treatment, or patient can say no for the surgery. So patient has the right. So it is autonomy. Next is the non-maleficence. It means do no harm. In any case, any circumstances, we should always think for the best interest of the patient. Next is beneficence. Beneficence means always doing good. In every circumstances, we should think of the patient's safety and always do what is good, ethically and morally. Next is justice. So justice is you treat every patient as equal. Equitable distribution of sources. So we should not consider कि कोई VIP है या influential person है, अगर OT में आया है तो उसको हम जो available चीज़ें हैं तो it should not be like that. Every patient should be considered equal and everyone should be treated fairly. Next is fidelity. So it means to be faithful. Faithful to the patient, faithful to the profession, and faithful to our area where we are working and to our colleagues. So if in recovery room a patient is there who has been operated and he's complaining of pain, and you say to the patient, I'll be right back with your medication, I'll ask the anesthetist or doctor, and then you go inside the OT, you forget about the patient, you are given some other work. Now the patient, the faithfulness, the patient will not have that faithfulness on you. So that is another point to be remember, fidelity. Sixth one and the last one is the veracity. So veracity means always speaking the truth or telling the truth. Now in veracity we can encounter the ethical dilemmas, like sometimes we are not supposed to directly tell the patient, relatives कोई कैंसर वाला पेशेंट है, कार्सिनोमा वाला है, some of the relatives say कि पेशेंट को नहीं पता चलना चाहिए पेशेंट. So here we face the ethical dilemma. So now I have told about the 6 ethical principles that we must follow in order to prevent us from landing into legal complications. Now there are some legal standards in perioperative nursing. So I want to ask you all, what do you understand by perioperative nursing? Anyone from the audience? Perioperative? So perioperative includes all the 3 phases in the OT, like preoperative, intraoperative and postoperative. So all 3 aspects we should be very careful, and we should follow the legal standards. Now these are some of the key legal considerations. Like first one is the informed consent, patient safety, documentation, confidentiality and privacy, scope of practice, and professional development and continuing education. So we'll see each one of them one by one. So first is the informed consent. What is informed consent? So basically in the informed consent, three major aspects are there. The informed consent, patient is informed about the advantages of the surgery, disadvantages of the surgery, and any other alternative. So these three contents should be covered in the informed consent. Informed consent itself, the name implies that the patient is informed about all these things. So now you can see the essential elements are diagnosis explained, fair explanation, description of alternative treatment, benefits, and any other procedure. Now the patient has the right to refuse or accept. Now there are some requisites for the validity of informed consent. If all these things are not followed, then the consent remains invalid. So it should always be written. In written permission should be taken, signature of the patient should be taken, and if the patient is not able to sign, means the patient is under 18 years of age, or the patient is of any psychosis, delirium in condition, unconscious patient hai, then any guardian can sign on the behalf of the patient. But it should be mentioned in the consent ki what is the reason of the guardian signing on behalf of the patient, it should be mentioned. It should be obtained before sedation. It should be secured without pressure or threat. Here I would like to give my example. In 2014, when I was admitted for my first delivery, so in labor room, as I was influenced by some of my colleagues and the doctors I was working with, so they told me that the epidural anesthesia is best. So why to go in such intense pain, and you can take epidural anesthesia. So I opted for epidural anesthesia in the labor room. Now the JR, the most junior JR, she came to me with that consent form, and she stood before me, and I am in the labor pain and she's telling me, यहाँ पे आप साइन कर दीजिए, इसमें लिखा हुआ है आपके बच्चे की धड़कन बंद हो सकती है, आपके बच्चे की जान को खतरा हो सकता है, and all these things. And luckily, fortunately, my sister-in-law, she used to work here, she was sister in charge then, she was there with me, and she told the JR that, ma'am, this is not the right way to take the consent, give us some time, we'll inform you about our consent, we are willing or not. So the witness, it should not be secured with threat, always explain in a language that patient can understand. So adult can sign on their own, and for minors, patients or parents or guardians can sign. As I told you, mentally ill or unconscious patients, the guardians can give consent on their behalf, but the reason has to be mentioned in the. Now the informed consent is again a legal document. It can land us into legal complications. So the consent must be filled completely. And in case you have taken consent today and the surgery gets cancelled, so you think you can use same consent for the next day, you strike out the date, so it is not ethically and legally it is not correct. You have to fill another consent. There should be no cutting, no erasing, no overwriting over the consent form, and it should be completely filled. Now another question arises here, who takes the informed consent? Who takes the consent? Exactly, the doctors has to take the consent because they have to explain the procedure. But our role in this informed consent is when patient comes to OT, you have to check the file of the patient whether the consent is taken or not. And in the witness, the nurses who are those posted in the ward, they sign on the side of the witness. So this must be taken care of. So now next point is the patient safety. So to keep the patient safe in the perioperative nursing phase, we are responsible completely. So I hope you all follow this patient safety checklist in the OT. So if you are following it religiously, I can say that there is 0% of errors in the OT if we follow it religiously. So as I have an experience of ortho OT, so sometimes patient in the OT is nervous, anxious, and he is not able to comprehend what we are saying because there are so many people around. So in OT what we practice, like if a patient has come for TKR, total knee replacement, so we used to, like in sign-in, we have to ask the patient, and patient has to confirm the identity or the site. So we used to ask the patient to touch the knee, which knee you are undergoing surgery, like left knee, patient might say दाहिने बाहिने, वो समझ नहीं आता सब लोगों को, patient may not understand दाहिने बाहिने, so we ask the patient to show by touching their knee which knee they are undergoing the surgery. Again, identification of the patient is very important. So in identification of the patient, we should always use two identifiers, that is name and UHID, because name can be confusing. Two patients can have same name, and you might be knowing internally there may be many errors that might have happened earlier previously, but that things do not come out. So you might be knowing that there can be errors leading to confusion in names. So if you are following this safety checklist, I can say that there can be. So next is patient identity. You can check with the file. Armband also patient comes with the name. Then you can verbally ask the patient about the name, procedure, operative site, and you should document the allergies in the file. In the safety checklist, you document the allergies if patient has any, and then all the solutions that are used in OT, like PrEP solutions. Some patients might have allergy to betadine, iodine allergy they have. Then some of the solutions that are used in OT are highly inflammable or toxic. From my example, I can say that once there was a patient who had this plaster in the leg, and then he was posted for surgery. So that plaster was very old, and the skin under, when the plaster was cut out, the skin was very mottled and very scaly. So we thought of cleaning the skin before the surgery so that there is no chance of infection. So what we did, we used ether. Ether are present in OT, so ether used to be used as anesthetic agent previously. Nowadays it is not used. So we cleaned the skin with ether, and the skin was as clear as just like a baby skin. But then what happened, as the surgery started, as soon as the cautery was the bleeder was cauterized, there was a fire on the limb. But it was not a huge fire, but then again, so again there can be, it is a risk for patient safety. Okay, so all these things you have to keep in mind. Remove jewelry pre-operatively, or if it is not removable, paste plaster over it. While transferring the patient on the OT table, make sure patient does not fall. Always follow the checklist, because as a human mind we might forget something, so always follow the checklist. Now inside the table, always try to protect the body from the metal parts of the table. All the electrical safety of the instruments, equipment should be monitored. In case there is some special case posted and you need microscope or any ultrasonic scalpel, so you receive the OT list one day before. Make sure all the instruments and equipments are in working condition, and if not, you have to inform the surgeon one day prior or before the patient comes into the OT and it is sedated. So give special attention to pressure points. Then while shifting the patient from OT to ward, give special care to the all the lines, tubes, especially documents. Handle the documents very carefully. Some of the procedures are only diagnostic procedures in surgery, so the diagnosis of the patient is based on the specimens. So carefully handle those specimens, store those specimens if you have to send next day, and the medium where you have to store, agar formalin dalna hai, normal saline dalna hai, all these things you have to keep in mind. So this is a modified Eldred score. If you have to shift the patient from recovery room to a ward, you can use this score. It is a standardized tool, and if the score is more than 9, then the patient is safe to transfer to the ward. Now documentation, third point is, it is very important. So all the documentation should be made accurately. Document the names of each and every personnel that is in OT and that is involved in the surgery. Also write the name of the relief person, those who are relieved. You also document them. Also document the procedures accurately. For example, I have given here, sometimes in the OT list it is mentioned colonic pull or gastric pull. So oblique में दिया हुआ है. So after the surgery, which procedure is done, you have to document in the book. Also document the time. All document the count, sponge count, needle count, suture count, all these things to be documented, counted, and if there is a discrepancy, you should ask the doctor to get the patient fluoroscopy done to rule out any chances of any instruments or sponges missing. Record the intra-op medications, especially for the narcotic drugs that is used in the OT, because in the NABH procedure, if you all know, the storage policy of narcotics and the documentation is very important. All the specimens I have already told you. Any surgically implanted items that are there, you have to maintain in the documentation in the patient file also. And if the surgery is cancelled for any reason, you have to document in the patient file, and while transferring also what was the reason for the surgery to get cancelled or postponed. Now always, fourth point is confidentiality and privacy. Always maintain the privacy of the patient. We are living in an age of digital era, so we have phones with us. We click pictures, we post them on the social media, unknowingly or knowingly. So these all actions or ours can lead us into legal complications if in the near future अगर patient complain कर देता है, कुछ भी कर देता है, तो it can lead to. So always secure the patient documents. उनको किसी उनको restrictive area में कहीं ऐसी जगह संभाल के रखना, so that it is not mishandled. Now scope of practice is the activities that we are supposed to do, and we have the boundaries. So वही activities we have to do in the OT also. We should not go beyond our scope of practice, because if we go beyond our scope of practice and if any complaints is made, we can go into legal complications. Last point is the professional development and continuing education. So always what we learned in the GNM, what we learned in the BSc, what we learned in the MSc, it is a continuous process. In OT also you may come across जो पहले 2008 में जो instruments OT में होते थे, they are no more in the OT. We have so many new sophisticated instruments in the OT. So it is our duty to improve our knowledge and our learning. So if, for example, like for our DNC renewal also, we need to show the in-service credit hours. So that means they also know the importance of continuing education. Legally and ethically, if your license is मतलब renew नहीं किया है, it is expired, so we cannot practice legally and ethically. We cannot practice if the license is expired. So in order to renew our license, we have to undergo such continuing education programs. So in conclusion, I can say that the legal and ethical responsibilities of nurse in OT areas has increased tremendously, and therefore we should always keep ourselves abreast of the current situations, current techniques. And if we do not do this, not only we are harming the patient, we also can land up into legal complications. So we should always think about the ethical considerations, what is good for the patient, and always we must work in the best interest of the patients that are our clients. So thank you so much for your patient listening. I just rushed up my topic. Thank you so much.
Yeah.
Okay, so अगर unknown patient कोई आता है, emergency है, life threatening situation and patient has to go surgery, then usually the duty officer जो है, he signs the consent form. Duty officer sign करता है.
Yeah, for the further questions and further clarifications, we can first congratulate her. And I would like to congratulate Ms. Apana for covering such a big and debatable topic in a prescribed time. And it's a day-long topic. You can go on discussing about those things. And almost he covered the topic which includes everything in the OT. And I congratulate you for that. And one more thing, just I would like to know for the benefit of the audience, like consent. When you are talking about the consent, you just told us about the informed consent. That's very good. Like you covered everything. So sometimes what happens in the OT is, like I did not work in the OT, but still I can understand. So we take the consent for the particular procedure. And when you go into the OT, patient can go into the different procedure also, like extensive surgery or extensive some radiographic studies or something like that. How we are going to take care of that part of it?
Ma'am, actually the consent is taken for the proposed surgery initially. See, so now the patient goes inside the OT and then the plan changes. Okay, so like laparoscopic surgery होना था, but patient को अंदर लिया OT में and the plan changes, open करना पड़ा patient को. So again, the consent should be taken from the patient relatives, those who are there near blood relatives. We have to take the consent for the ओपन सर्जरी के लिए कंसेंट लेना पड़ेगा, बिकॉज हम ऑलवेज प्रपोज सर्जरी के लिए कंसेंट लेते हैं विच इज प्रपोज, बट देन इफ प्लान चेंजेस वी हैव टू टेक द कंसेंट अगेन.
So that means every time the relatives will be available at the surrounding of the OT premises. And if at all, if the relatives are not there, yeah, they are not traceable or something like that, we say that surgery will happen 2 hours or 3 hours, relatives may leave. At that time, what is like, do you have any written policy there in the OT, like in our OT? So who can give the consent for the particular surgery, like particular part of it? Do we have?
No, that time, ma'am, we informed to operating surgeons that you have to take the consent for further surgery, and if the relatives or brother or sister of the patient is not present there, then we inform the operating surgeon. He will take consent after coming to relatives. But without consent, at that time, we can't stop the procedure.
So, ma'am, the operating surgeon and any other surgeon who is senior to him or superior to him, if he's in OT,
Yeah.
then they both can decide together
Yeah.
that it is in the best interest of the patient and it is life-threatening.
Yeah.
Then they both can give consent and continue with the
As
surgery.
she already told कि laparoscopic surgery चल रही, फिर open करना पड़ा, तो फिर मैम उस टाइम हम we can't wait कि till
No,
patient
but still
relative.
we cannot wait, but still the consent should be there. Like we should have the clear-cut instructions for the people who are working in the OT. So because now we are leading with the ethics and the legal issues. The legal issues are the very like hard and fast rules, like what are the protocols which we have. So for the nurses, so who
Please keep
are,
silence.
like nurses who are like to work in a, like to be safe from our side, we have to understand the policies and procedures of the institution so that we can safeguard our patients as well as ourselves. That is what I feel myself like. Thank you so much, Arpana, for that. And any doubts for audience to ask?
I think for the routine surgeries, relatives are always there.
Hmm.
If something goes wrong and we have to plan, expand the procedure, then we definitely go and tell the relatives also and take a consent in between. So relatives are always there for the routine surgery. Of course, in trauma, there might be somebody is not there, then surgeons or duty officer have to take a decision to save the patient's life.
All major cases, surgeons already informed to the relatives that all the complications and
that comes under the informed
complication,
consent.
any circumstances, they can take decision for the betterment of the patient. So there is no wait for the relatives.
But
and
still we
anything.
need to prepare
But
for the worst
on the
cases
second hand,
scenario.
they send the resident and wait for the
Yeah.
their relatives, and that things would be doing in the back of the end, and
Yeah,
the
thank you.
surgeons are doing their
Yeah,
work.
got your point. Thank
Yeah, sometimes depends on the condition of the patient. If patient is in condition of life threatening, we are not waiting for consent. So they continued their procedure, and on the back of the end, the resident is take care of that.
Okay, fine. Thank you.
Yeah.
Yeah, some.
But and recently, like NABH, when we went through the NABH accreditation program in surgery block, what they said, like it's not like any extensive surgery if you are doing or any changes in the procedure what you have taken the consent, it is mandatory to take the consent from the relative. If at all, if it is not possible to take the consent from the relative, one more option what they explained is you have to take the consent from the HOD of the department or the any other senior person available at that time in the OT theatre. So they have to discuss and they have to give the consent on behalf of the relative. That's what they explained to us. Like one more thing, like what they can do is different same OT, some other surgeon will be there beside you. They can take the consent from that person. But without the consent, we are not going to do any procedure. That's what they said. Even for any extent, even for the laparoscopic you have gone and explorative you have to go. For that also consent needed.
That consent they already taken, ma'am.
But
In
any that also they said.
No. All laparoscopic surgeries are
No.
joined with the
Yeah,
open
yeah, I
surgery,
know.
so they take both the consent for
No, that's
laparoscopic
what-
and
yeah.
for open.
That's what
they
they
don't
said.
perform laparoscopic surgery without consent of laparotomy. They already have taken.
No, what
That
they
is the
said, like,
mandatory for that.
like what we write in the consent form is what we write, like proceed, exploratory laparotomy and proceed, like that we write, no? But what they said, that consent form is not valid. That's what they said. They may come to the main hospital also, they may have the problem with the same issue. So what they said is they have to write the particular surgery, whatever their plan, they have to write it, and if there is any plan of change, again they have to take the consent. Without that one, our consent is not going to be valid in the court of law. That's what they said. Okay.
Anyone? Anyone want to ask anything from theme is OT? So I think there must be some questions for OT nurses. No one? And nowadays we OT nurses have to be very vigilant while, as Aparna told, patient confirmed identity and site, patient is NP or not, antibiotic is given or not, or patient have any allergic, to prevent the complication of the patient and legal complications also. So we should respect the patient belief and value also. That time patient may have follow some customs, मान लो कोई धागा बांध के आया कि मुझे नहीं हटाना है, और वी नो कि ओटी में धागा अलाउड नहीं है, तो हम उसका धागा खोल के उसकी जेब में रख सकते हैं कि ठीक है आपके साथ है पर आप अलाउड नहीं है. तो वी शुड बी टेक केयर ऑफ आवर पेशेंट ऑल्सो. एनीथिंग एल्स? No one. All clear.
Thank
Good.
you, Ms. Aparna. Now I will call Ms. Nargis ma'am and Shubha Lakshmi ma'am to facilitate our speaker and respective panelists.
Are you all tired? Are you tired? Actually, there are lots of discussions going on at the back. If you have any doubt, you can ask, right? Okay, now we are moving on to the next session. It's going to be interactive now. It's interesting also. It is operation theatre management of esophageal as well as stomach surgery. We are going to talk about that. The speaker is Ms. Rupali Verma. I request Rupali to come forward. We have there. Okay, so we have Dr. Vignesh here. Sir is a senior resident in GI surgery department. I request Dr. Vignesh to give a talk on surgery for esophagus and stomach surgeries. So welcome. Moderators. So I request Sister Madam Vasundhara and Madam Nargis to be the panelists for this session. Please come forward. Mr. Madan also. Sir, over to you.
Good afternoon, everyone. Welcome on behalf of AIMS GI Surgery Department for this to this meet, and also on behalf of RNR. So this topic per se is very important from the surgery point of view also, because we in the GI surgery AIMS department, we are very fortunate to have a great team of assisting scrub nurses under Nargis ma'am, so that this session, this interactive operative management session is very important, because from surgeon's point of view, I can assure you that if having a good capable assisting scrub nurse with us will relieve half of our mental as well as physical fatigue. So we are very fortunate for that here, because we have a great capable team of scrub nurses with us. So this right from the consent we have talked about in detail now, right from the consent, right from the positioning, anesthesia, the WSO checklist which we start with the sign in, sign out, time out, everything. So everything, the sisters are the in charges for the entire thing. So we just the surgeons will just form a part of the team. We just do the surgery, but the entire management and the authority is with the sisters only. So this part will be very interesting, and I am very looking forward to the questions you all have. So the main session will be presented by Rupali sister. So I'm just here to give a introduction about the surgery part of the esophageal and gastric surgery. So as you all know, we can have either a benign surgery or a malignant surgery. So right from the beginning, for any surgery, if we see patients, we'll have to see from their age, sex, everything. So benign patients will be young patients who can withstand long surgeries, withstand serious major surgeries, and old malignant patients will always be frail and they cannot undergo a major surgery. So esophagus, the most common surgery which is done is for malignancy. So in malignancy esophageal surgery, the main uniqueness about the esophageal surgery is that we operate in 3 different areas. One is in the neck, one is in the chest, and other is in the abdomen. So obviously for the abdomen part, for all the laparotomy instruments, we will be needing that. And we always open the neck and the abdomen simultaneously. We have 2 teams of surgeons operating simultaneously and 2 sisters separately assisting us. So and the positioning, the requirements, everything will be covered. So the main issue here is the necessity for thoracotomy conversion, because the most common surgery which we do here is a transhiatal esophagectomy. The esophagus is a very blind organ. It is inside behind the heart, between the heart and the vertebra. So it is a very blind space. So most of the surgery, esophageal mobilization, would be done just by palpation, feeling the esophagus, and there is a high risk for bleeding. So we'll always ask our sisters to keep a thoracotomy set ready. So whenever there is uncontrollable bleeding or we find that there is dense adhesions, we are not able to remove the esophagus, then there is always, and we'll take the consent beforehand also, all the patients there will be a consent and there will be a thoracotomy set ready, because whenever there will be a possibility that we'll have to convert it into a thoracotomy. And coming to the neck part, again because for the neck surgery we need the esophagus to be extended, the neck to be extended, so we will position the patient accordingly. And at that time also, along with the anesthetist sisters and us, we will be making sure that there is no muscular injury or tracheal injury during the positioning of the patient. And once we remove the esophagus, again through the chest we will have to take up the stomach tube and anastomose it to the neck. So compared to this esophageal surgery, the stomach surgery would be only dealing with the abdomen part in most of the cases, and we might need to go into the chest in some cancers of the esophagus gastric junction, but most of the gastric surgeries, either benign or malignant, will mostly deal on the laparotomy. We might need some better retraction during the gastrectomy surgery, so we might need a self-retaining retractor such as a Rochard or a Thompson retractors, so it has to have a good exposure near the diaphragmatic parts. But the rest of the chest and neck would not be accessed in the gastric surgeries. The main requirement would be the abdomen and laparotomy set only. So I'll be here. Rupali sister will start all the intraoperative management, the preparation, what all instruments and equipments you'll need. Thank you, and I'll call sister to start the session.
Thank you, Dr. Vignesh, for the brief introduction. Good afternoon, everyone. My name is Rupali. I am going to discuss on the topic operation theatre management for esophageal and stomach surgery. Starting in the introduction, esophageal and gastric and any kind of surgery is being performed when there is any kind of abnormality or cancer is present in that region. In order to cure such type of conditions, we perform different types of surgery that we will discuss in this slides. So coming to the esophageal surgery, these are some indications. Number 1 is cancer esophagus. Then corrosive ingestion, any kind of corrosive like some people take up like phenyl and some corrosive ingestions. Then esophageal perforation, esophageal stricture and esophageal malformation. These are some kind of indications. Now esophageal surgery are of 4 types. We perform, the main is transhiatal esophagectomy as told by Dr. Vignesh. Then is transthoracic esophagectomy. Then thoracoabdominal esophagectomy and VAT surgery. VATS is video assisted thoracic surgery. We are going to discuss one by one. So coming to the transhiatal, that is through the diaphragm. As you can see in the picture, Incision are made in the first in the abdomen and then in the neck surgery simultaneously, as been discussed. It is also known as Oringer surgery. In this, the position is a supine position with neck extended and turned to the right side, because we have to reach the esophagus that is in the left side. So we turn the neck to the right side. This is the position, and the you can see the in the neck region there is a muscle. Through this muscle we give the incision, sternocleidoid mastoid muscle. This is the draping pattern in which neck and abdomen both are exposed for the accessibility. Now coming to the esophagectomy. If there is any kind of tumor, we do esophagectomy. So if there is tumor in the GE junction, we will particularly talk about GE junction, then we can do the classification according to the Sivert classification. Sivert 1 and 2 need esophagectomy, and Sivert 3rd needs proximal esophagectomy and margin of Rosen. And negative and positive margin gives 2 types of surgery. Negative will be gastrectomy with RYEJ, and if it is positive, then esophago gastrectomy. Complete esophagus and gastrum will be removed. And in the other picture, you can see we cut the gastric region for the gastric conduit to pull up the gastric region to the next side. So this stapler which is used is advent. We don't use this advent stapler, we use this NTLC stapler. NTLC is a new transisting linear cutter. So it come in 2 different size in our OT. First is 55 mm and 75 mm. According to the size which we are, the size of the region from where we have to cut, we use different types of sizes of the stapler. So it is intended for transection, resection and creation of anastomosis simultaneously by using these staplers. Other kind of stapler is echelon. This echelon come in 2 types of sizes, that is 45 and 60 mm, and it has different types of color coding, and the color coding is based on the tissue thickness. The tissue thickness will tell which type of color coding, like in intestine we use mostly blue color code, blue cartridge for the anastomosis. So according to the surgeon's choice, we can use this color coding. Now this is a video using of NTLC stapler cutting of the gastric region. This gastric region is been marked for cutting, and now this NTLC is being used for cutting the gastric region. This is basically a gastric conduit. This stapler is being used. This is gastric conduit that we pull up the gastric conduit up, and then we will anastomize in the neck region. And this is the THE specimen, transhiatal esophagectomy specimen, that we cut out in which a tumor was there. Next is anastomosis after pulling up of the gastric or colon region that we have made. As I have told in the GE junction, if we take out total gastric region also, then there is colonic pull up, and if we cut half of the stomach, then there is a gastric pull up. So we use different types of sutures. It can be according to the surgeon's choice, or 4-PDS, 4-Prolene we can keep ready. This is the anastomosis of gastric conduit. Now preparation for the surgery. This is our main part of the nursing side, but we prepare for this type of surgery. So we basically work in 2 teams simultaneously. One is the neck region and second one is the abdominal side. So set which are used to prepare these neck and abdominal side are laparotomy or major, then vascular set and dressing basin that we use. And as Dr. Vignesh has told, that we keep the set thoracotomy instrument standby. So if there is any bleeding in the thoracic region, we can open it immediately for under vision dissection. Then this is the neck side trolley. These are basic instruments like mosquito, artery, Babcock, Ellis, needle holders according to the size of the depth of where the surgeon is performing the suturing where it is being done. Then these are fine instrument. In the neck side we use fine instrument for the surgery. Then these are half tie length pseudopack to tie any kind of vessel, and these are LT applicator. I will discuss it later. And the special arrangements are skin hooks for the skin retraction and Langenbach retractor. These are Langenbach for retraction of the sidewall in the neck. Then this is a red rubber tube. Not only red rubber tube, any kind of tube which can be used for the identification of the esophagus for the dissection can be used. Then this is abdominal side preparation. In this we use long instruments for the long and short both according to the depth. We use these instruments, same artery, mosquito, Babcock's, but according to the length we keep these instruments. And the scissor must be long preferably, and big size of the blade for the skin incision. As you can see in the bowl, there are some slings. These are used for identification of the artery, veins and cystic duct. So these are the color coding red, blue and yellow respectively. Then these are some retractors. This one is Harrington retractor for the retraction. Then is Morris retractor, and then is Journey's retractor. These are being used at different stages of the surgery. These are LT clip applicator. LT clip is used for the ligation. These are basically titanized, not being removed later on. These are kept in the patient's body. These are 100, 200 and 300 according to size of the vein which is where it is being applied. We can use these LT clips. Then energy sources. Number one is harmonic to cut and ligate simultaneously. Then is extendable and normal cautery. Extendable cautery can be used in depth. After extending, we can cut in the depth region, and these normal cautery can be used in the starting phase. Then is bipolar cautery. This is a video of extendable cautery. You can see how we can use in the operation theatre. Then coming to the harmonic machine, I have seen in previous picture we have seen harmonic. This is the harmonic machine. Then this is the cautery machine in which bipolar, monopolar both are being used. Then a special arrangement in the abdominal region. This is corrugated drain. This corrugated drain we use in our settings, and in other setting there can be used Penrose drain to pull the gastric or colonic conduit, to pull up when we cut the gastric or colonic region for the pull up. After that, to pull that region, we use this corrugated drain or Penrose drain. Then sutures. This is according to the surgeon's choice, but we can keep ready like 4-OPDS, 4-Oproline, 3-O-Vicryl. This should be kept ready. And the small sutures should be like I have shown in the picture. These are vascular needle holders. Small suture like 4-O, 5-O, 6-O should be loaded in the vascular needle holders, and according to the depth, the length of the needle holder should be seen. Now second one is transthoracic or through the thoracic cavity. In this incision are made in the abdomen and one of the chest, and also this is also known as Ivor-Lewis esophagectomy. Incision when made in the three incision are made neck, thorax and abdomen, that is then it is known as McNewn esophagectomy. For preparation we prepare the same as we have done in a transhiatal esophagectomy, same instrument, but thoracotomy instrument should be kept along with us. In this position, as you can see, patient is with the semi-decubitus position with hip rotated. This is not done in our OT, especially THE is done. Then thoraco-abdominal through the abdominal cavity, midline incision that get mostly extended to the left side chest, and position is supine. And preparation for this is general instruments and thoracotomy instruments we keep along with it, and sets are the that I have discussed before along with the thoracotomy set. Then video assisted thoracic surgery. Why video assisted thoracic surgery? Because if we have to do undervision dissection or to minimize the bleeding, we use a video assisted thoracic surgery. Many small incisions are made along the insertion of the surgical tools, lighted camera, and which are used in the during the procedure. All those types of tools which are used. Position are left lateral can be given, semi-lateral can be given, and in the picture this is the prone position in which the ports are being marked. Different types of ports are being used, size of ports are being used for the camera and the instruments. For this preparation, we also prepare two types of instruments. Number one is laparoscopic instrument that we will put inside through the ports. And second one is a general instrument that I have discussed before, that we have prepared in the THE. That is only the instrument. We also prepare for the open surgery also, because it can anytime it can be converted into open surgery. This is the position in the semi-lateral position, and port is being marked. This is basically a picture of the robotic surgery. This is not been performed in our OT, but this is a port position. Now stomach surgery. Stomach surgery can be included along with the esophagectomy, as I have discussed, and indication can be cancer, stomach, stricture, trauma, obstruction, any malignancy or GIST. GIST is gastrointestinal stromal tumors. This can be indication of the stomach surgery. So coming to the stomach surgery, these are also of the 4 types. Distal gastrectomy, in which all the part is being removed out. This distal gastrectomy is being removed out, but ligation of short gastric vessels, without ligation of short gastric vessels. Then a subtotal gastrectomy. Subtotal, only short gastric vessels are being ligated. This is a subtotal. Near total, when we ligate all short gastric leaving behind, cut off the stomach. All gastric vessels are being cut out. Total removal of the stomach is the total gastrectomy. Then this is the picture of the gastrectomy. Then this is near total gastrectomy. When we have done near total gastrectomy, this is the picture. And in the another picture, you can see the retractor. This is the Rochard retractor, which will be discussed in the later classes. This is a Rochard retractor for the retraction of means if we have no assistance, so we can use these retractors for its retraction and more space. For this preparation, I have discussed before. Sets are general instruments for this. Sets are same: laparotomy and major set, vascular set, and I have told Rochard and Thompson retractor that will be discussed later in the next session. And dressing basin are being used. And you can see in the picture the draping pattern for the exposure of the incision. Thank you very much for the patience listening.
Thank you, Dr. Vignesh, for your brief introduction, and for Neeru, our comprehensive, it's an extensive work, drape, position and instrument. She has almost discussed many things. Thank you so much, and over to panelists for their contribution.
First of all, I would like to congratulate her because she has explained everything so nicely, very oriented about the position, what will happen, what are the contraindication, indication for conversion to open from video assisted surgery, and I think it's very commendable for our topic. And still I would like to ask Dr. Vignesh if he would like to add anything in it.
Just like I said in the introduction, I had already seen her presentation. That's why I gave a very brief introduction, because she had covered everything. So right from the indication for what all steps, in each step, what all instruments, what different types of instruments, even small things like if you're in the depth, you need to give a longer needle holder. If you're in the surface level, a small needle holder, even the length of the ties. So all these things in the esophageal surgeries, we constantly move around between different stages of the surgery, different places of the body, from the neck, chest and abdomen, as well as in different planes. We suddenly go in the surface, we suddenly go near the hiatus in the depth, suddenly we go blindly behind the pericardium. So the sisters, they constantly see us, and based on the step we are in, they'll give us the instrument accordingly, the length of the suture, length of the ties accordingly. So that is the one interesting thing about esophageal surgery, and sisters covered everything in each step, what all we need, everything. Thank you.
I think in thoracic, whenever we open to thoracic surgery, and what all are the instruments required, she has mentioned. But the thing is, if there is an injury, we should be ready with the staplers. We have to to show a quick response as a, not only the scrub nurse but the circulatory nurse need to be very conscious about what are the things to be supplied when they are going to open a chest. Then there is another thing, if there is any leak from the lungs, then we have to open, put a sutures, and we have to ask anesthetist to give a more pressure to inflate the lungs to see the, and how to see if there is a injury to the lung or any vessel. For the vessel you need to put a staples, but for the leak you have to put a saline in the chest cavity, and if there is a air coming in it, then you have to visualize it and suture it to, otherwise the patient will have this thing. Persistent air leak, and then we have to put a chest tube for some time, so that there should not be any other indication for this thing. So thank you very much. This is the only more important point to be noted. And other thing, when we put blind this thing hand, even Dr. Dash started putting laparoscope through the instruments to see and visualize the dissection, because it is a totally blind dissection. The injury can happen at any time. Thank you very much.
Any questions from the audience? They are giving compliment to our speaker. Thank you so much. Now I request our DNS to felicitate our speakers. Sir, please come. Madam, please. Sir, please. Neeru, please. I request Mr. Kanish to present gifts for our moderators. With that, we stop here for pre-lunch session. We'll part for lunch and we'll come back for the post-lunch session. Come back in time, please. It's half an hour? It's half an hour lunch break. Please be back. By 2:30, we all expect you to be here. Enjoy your lunch. क्या हुआ?
इसी में उन्हीं को भी ऐड करना है।
ये तो पैनलिस्ट में
पैनलिस्ट में वो उसमें इसको पैनलिस्ट है।
इसके पैनलिस्ट ये दोनों के लिए
कौन कौन है?
पैनलिस्ट में नोट करेगा।
हाँ तो उनको ऐड करना है। वो जो मैडम सीरीशा कैंडिडेट सर्जरी के बोल रहा हूँ कैंडिडेट सर्जरी उसी में ऐड करना है।
सिरिशा ये है कौन मेजर मतलब
बाई फेस अभी
नहीं मतलब नर्सिंग
आर्मी
सर्जन
हॉस्पिटल
सर्जन्स में है।
एमएनएस मिलिट्री नर्सिंग सर्विस
अच्छा उनका मेजर ये अच्छा वो तो यहीं बैठती
इधर ही बैठती है तीनों साथ में।
हाँ, तीनों जन।
और एक मेजर रेशमी है उसमें कमांड हॉस्पिटल कोलकाता।
इसको फिर मैं नेक्स्ट में ऐड करूँगी।
वो नहीं उन्होंने बताया था रेशमी को उन्होंने बोला कोलोरेक्टल सर्जरी। कौन क्या नाम है? देखो शेडी पर आपका आपके पास एक और भी
ये तो कॉल करने से
इधर एंगल ग्रीन है मैम डॉक्टर मिस मैं तो सीरीशा को करने गया हूँ सीरीज हो गया सुमन लता ट्रांसप्लांट में आ रहे उन्होंने ट्रांसप्लांट इससे पहले उसमें पहले सुना ये जो नहीं मैम एक सेकंड ये जो दोनों इकट्ठे
ये
मैम ये तो ठीक है पैनलिस्ट ये है
ये
इसमें हम मैम ये लोग है ना ये सारे बाहर वाले पहले सर है पहले सर हो ना हो सीधी तो है सीधी सर तो है यहाँ पे अब मतलब 3-4 से तो है ना ऐड करेंगे नहीं ऐड तो कर पाएंगे मतलब देखो 3
तीन है
ठीक है मैम नेक्स्ट टेबल पे रख दिया था।
हेलो
जाना होगा तो दिक्कत मेरे वही टेंशन है मैं इसलिए यहाँ पे
ऑडियंस प्लीज मेंटेन साइलेंस। ये मेरा है ना, मेरा प्रेशर बैग, ये मेरा नहीं है, मेरा पेपर फेंक दिया आपने। पता नहीं, छोड़ो, मेरे से ज़्यादा।
हेलो
Hello. ठीक है, ठीक है. Welcome back, IASG midterm CME Delhi 2024. I hope you all have had lunch. और ये पूरी उम्मीद है आप सोएंगे तो नहीं. चलो. Okay, let's move forward. Our Next topic is basically on surgery for liver spleen, and in which Dr. Samidhi Shuda Datta, GI Surgery, Army, RR Hospital, New Delhi. I welcome Dr. Samidhi. And Miss Himani, Nursing Officer, AIMS. She will be covering nursing intervention part. I welcome you both. And as a panelist, we have Dr. Kailash, Major Suman Lata ma'am or Nargis ma'am. Please.
Hello?
Good afternoon, everyone. I'm going to present on operative theatre management for liver and spleen surgery. Now, firstly on to liver. Liver resections are mostly we are considering here, which can be non-anatomical and anatomical. Anatomical can be in form of hepatectomy or lobectomy, and non-anatomical is required in cases of carcinoma gallbladder. Now I'm going to discuss on hepatectomy because it's a major surgery. It requires a lot of dedication and meticulous dissection, and also it is done in cases where a lobe of liver has a cancer in form of hepatocellular carcinoma or intrahepatic cholangiocarcinoma. Also in some benign cases like RPCs, it may require a hepatectomy. Now, preoperative preparation evaluation is very much important in these cases because you have to have a suitable biliary and arterial and venous anatomy. But after all those considerations, let's say we have put up a patient for hepatectomy. So, the main principles of hepatectomy is you will control the inflow, you will control the outflow, and then you do the parenchymal dissection. So, the right lobe and left lobe of liver, they have a separate supply. Portal vein, they have right lobe has right portal vein and left lobe has left portal vein. Right lobe has right hepatic duct, left lobe has left hepatic duct, like an artery same. But in case of hepatic veins, the supply, the right lobe gets a supply from right hepatic vein and part of middle hepatic vein, and also the left lobe gets a supply from left hepatic vein and part of middle hepatic vein. So the portal dissection may be easier, but the thing is during the parenchymal transaction we will encounter the middle hepatic vein many times. So the dissection in the parenchyma is very important, and we have to be ready for a bleed, profuse bleed, venous bleed to the veins will collapse, it will be difficult to control. So after all we have done the higher dissection, we have in case of a right hepatectomy we have separated the right hepatic artery, we have separated the right portal vein and right hepatic duct, we have cut those things. Now we have controlled the right hepatic vein and middle hepatic vein, taken control. We have to do parenchymal dissection. The instruments that are commonly used here, previously it was used finger slices, finger fracture method. Right now we use mostly CUSA and harmonic for the dissection part. So in this case it is a very slow procedure. It sometimes takes more than 2 to 3 hours and 4 hours. Sometimes you encounter bleed, sometimes you encounter bile leak from the surface. But all said and done, if the surgery goes well, the patient may, and mostly the patient loses blood around 500 ml to 600 ml. But in case of, if you are not alert, they may lose up to 1.5 liters. Post-operatively also the patient also has a leak, risk of bile leak and bleeding from the cut surface. You control those bleed with argon that we have right now in our armamentarium, and also Surgicel and fibrillars, all those things. So I think that's it for the hepatic surgery. And for spleen surgeries, I would like to discuss on PSRS, which is a shunt procedure which is done for refractory varicose bleeds, hypersplenism, and sometimes in ascites, when the other main conservative procedures are not able to control the disease. Disease in this case is mostly HPV and NCPF, and this procedure is commonly done in AIMS hospital. In this case, there is a splenectomy is done, and the splenic vein is connected to left renal vein. Now this also requires a very meticulous dissection, because thus there are sometimes multiple collaterals. Spleen has a supply that is abundant with blood basically, and it is not a linear supply. It sometimes have multiple branches that is going out. So the taking in this surgery, firstly you have to take control of the splenic artery wherever you can find. Mostly it is found over the superior surface of the pancreas. You take control of it. When the blood doesn't go into spleen, hopefully the bleeding will be less. And then you go towards the splenic hilum. But before that, we have to take out all those ligaments which are there. The gastrosplenic, linorenal, splenocolic, those ligaments. And then you have to reach for the hilum. You have to meticulously tie all those splenic, small vessels of splenic vein. You have to even preserve the length of the splenic vein in this case, because you have to later do a shunt with that vein. And then you have to, I think, you have to free about a 5 to 6 centimeter of length if you can get it. And then you have to do a dissection over the left renal hilum and do a shunt, which requires a microvascular anastomosis. And it is a advanced procedure, I would say, and this procedure, all these procedures, they require a lot of meticulousness, and it may have some torrential bleed in between. So I think those things have to be considered from a nursing point of view in a surgery, these surgeries of liver and spleen. Now back to Ms. Himani, who will present on you how to do the operative theatre management.
Thank you so much, sir. Okay, myself Himani, and I'm going to discuss operative theatre nursing management for liver and spleen surgery. So first come to the introductory part. Liver surgery refers to a range of surgical procedure performed on liver to treat various conditions like benign and malignant. The surgery which are included in this presentation, that is hepatectomy, extended cholecystectomy, hydrated cyst of liver, and the wedge resection of the liver. So first come hepatectomy. So also known as liver resection is a surgical procedure in which the surgeon removes entire liver or the part of the liver. You can easily see in this picture, this is the specimen of the partial hepatectomy, and this is the hepatectomy, when the surgeon removes the entire liver, called hepatectomy. The hepatectomy, we can see the entire liver is removed in the liver transplant. Next is the extended cholecystectomy. In this, remove the entire gallbladder, small section of the liver next to the gallbladder, lymph node, and a small section of liver is also removed. It is done when the cancer is spread throughout the gallbladder. Next is the hydrated cyst of liver. It's a parasitic infection caused by the tapeworm. Next, wedge resection of liver. In wedge resection, the surgeon removes a segment of liver or a tumor part. Okay. So this is the theoretical part. So come to the main topic, that is operative theatre nursing management for liver and spleen. So first, before going to the topic, first we discuss the basic. What are the best practices for the scrub nurse? What are the techniques we should follow in our OT premises? Okay. So for the elective surgery, in our OT for the elective surgery, one day prior we get the information or the OT list. So audience, this is a discussion class. I hope you all participate. So what we done when we get the list? We check the patient details, the diagnosis, and the surgery. So first, suppose hepatectomy is posted in our OT. So what should be kept? First is the check all the supplies, check all the instrument set which are available or not, and inform the prior. Okay, and machinery part is ready or not, it is in working condition or not. Like for the hepatectomy, we need CUSA and argon. So it is in a working condition or not. So these are the basic things we should kept in our mind before surgery. Okay, so next come to the techniques for safe and efficient instrument passing. So apart from the topic, these are the basic tips I should discuss with you. So I hope most of the audience are the OT nurse. So anyone from the audience can discuss what are the technique we should follow when we pass the surgical instrument. Anyone? Okay. For all the sharp, we can use kidney tray to avoid injuries. Okay, to avoid sharp injuries. Thank you, ma'am. So here is a video, short video. So in this video, the nurse hold instrument by their handle or hold the instrument by their hinge, and before passing, she should check its working condition and the sharp things towards yourself. Okay, in passing the instrument, we are using palm to palm techniques. So this is the palm to palm techniques. We firmly place the instrument in the surgeon hand. Okay, this is the right technique of passing the instrument in OT premises. Next is the sharp. This is the in this video you can easily see what the correct method. Okay, we are using needle holder or straight artery for removing and inserting the blades. So these are the some basic things we should keep in our mind. Okay. Next, operative theatre nursing management. First, as we already discussed, before surgery the nurse should verify all the necessary supplies and instrument sets required for the surgery. The WHO checklist should be completed. In this includes sign in, time out, sign out. Okay, the circulatory nurse or scrub nurse should check the consent, should identify the patient, should check the procedure. Okay, so we can skip this part because this is already discussed. So positioning the patient for surgery. So for the liver surgery, we should position the patient supine with the arm extended at the right angle to the body. You can clearly see in this picture. Next is the incision. Surgeon make an incision across the right upper abdomen below the rib cage. So come to the instrument set. What are the instruments we required for the hepatectomy or for the liver surgeries? So we need three sets, that is major or lab set, vascular set or the retractors, that is Thompson or Rochard. Okay. Major or laparotomy set. Laparotomy instruments are needed, but the number varies according to the surgery and the size of the instrument according to the surface. If the operating surgeon operating in the depth, so we are giving longer instrument, and if the operating surgeon is doing in the surface or a superficial, so we are giving the smaller ones. So these are the laparotomy set. Okay. Next is the vascular set. So as we all know, liver is a highly vascular organ and there is a chance for the bleeding. So we need vascular sutures for this. So okay, so vascular set include vascular needle holders. For the 4O, 5O proline, we need vascular one, and for the fine sutures like 6O, 7O, we need the castor needle holder or micro needle holder. This is our normal vascular needle holder, and this one is the micro needle holder. Next is the vascular forceps. Vascular forceps provide a secure grip without causing any trauma and damage to the vessel. So when the surgeon is dealing with the delicate vessels, so we are using vascular forceps. Next is the vascular loops and slings. It helps in isolating, retracting and occluding blood vessels. We have color coding for this, red for the arteries and blue for the veins, and the yellow one are for the nerves. Bulldogs and the vascular clamps. So vascular, we have in our vascular set we have Sertinsky and DeBakey clamps, and for the smaller, for occluding the smaller blood vessels, we are using bulldogs, and for the bigger one, clamps are theirs. Next is the rubber shot. Rubber shot, it helps to protect the suture for kinking. It prevents the suture from the laceration or breaking. So we are putting some IFT or rubber tubes in the small mosquitoes. Next is the retractor part. The purpose of both the retractor are same. In our OT, we are using Thompson and Rochard. For the hepatobiliary procedures like hepatectomy, we prefer Thompson as compared to Rochard because it have more retractors and exposure is more. So this is Thompson and this one is the Rochard. Next come to the machinery part, which energy sources we need for the hepatectomy or liver surgeries. First is the monopolar cautery. So when we are using monopolar cautery, what point we remember? What point we kept in our mind? Anyone? Cautery pad. Okay, because without cautery pad or earth pad, patient can get burn. Next is the bipolar and third one is the harmonic and CUSA and argon. So let's discuss the CUSA because it is very important for the liver surgery. CUSA machine is the Cavitron ultrasonic surgical aspirator. CUSA machine have three functions. First, it delivers ultrasonic waves. It function as an aspirator and it also irrigate. So it in this CUSA delivers ultrasonic frequency to emulsify and remove the target tissue. So and it irrigate the area with the sterile saline and aspirate the same. Okay. So here is a short, this is the CUSA probe and this is the CUSA transducer and this one is the, one tubing is for the aspirator and other one is the irrigation. This is our CUSA machine. So in this video you can clearly see before giving to the surgeon, the nurse should check its the working condition, it's functioning or not. Next. So CUSA doesn't have tendency to coagulate. So for the hemostasis, surgeon uses extra ties, that is non-absorbable cell ties or the LT clips. You can see in this video, the operating surgeon uses LT clips or in our OT multi-clip fire are also available. This is the pre-loaded LT clips. It helps in reducing time. Next come to the argon machine. Argon beam coagulator is a non-contact monopolar electrocoagulation device that transmits radio frequency electrical energy from a handheld electrode across a jet of argon gas. So this is a monopolar. So in this we also kept in our mind that the extra earth pad is required. So scrub nurse or circulatory nurse should ensure that the earth pad is attached. This is our argon probe and this is the argon machine. Next, here is a small video. In this video, nurse check its working condition before giving to the surgeon. Next is the hemostatic agent. So there in the liver surgery there is a high chances for the intra bleeding. So we should always ready with the hemostatic agent or the standby. So in our OT, the surgeon uses snow, Surgicel. Here, this is a snow, Surgicel, Surgiflow, Flow Seal, Tissels, Liga clips. Liga clips are made up of titanium. It's remain inside the body. Pseudopax, for the ligation of the vessel, surgeon used Pseudopac, multi-clip applier. Okay. Next is the spleen surgery. So in our OT, PSRS is the most common. So proximal splenorenal shunt. It is performed to decompress portal hypertension in patient with refractory varicose bleed, especially non-cirrhotic portal hypertension. In this, spleen is removed and the shunt is made between the splenic vein and the renal vein. So position is different, that is semi-prone with the left side up. Incision is the left oblique thoraco-abdominal. Next is the special requirement. The instrument set of the liver and spleen surgery are almost same. The special things we required is the chest spreader. Previously chest spreader was used, but nowadays Thompson is more preferable. Next is the heparin saline. The ratio of the heparin saline is the 1 ml in 200 saline. In our OT we using this ratio. Then the renal clamp and the port scissors. Okay, thank you. So this is a discussion class. Any question from the audience side? And panelist wants to add something?
So, thank you, Himani, for a nice overview regarding theatre management in hepatosplenic surgery. So, as you know, the outcome of any surgical process, whatever, whether liver resection, esophageal colorectal surgery, it is depend on the team approach. So, surgery, especially intraoperative, is a team approach. So, as you mentioned, everybody should know. Start from the we receive the OT list. So everybody should be familiar about what the procedure, and though the WHO checklist is meant for just when the patient comes to OT there, but I think this is again important. We should start when we receive the OT list. As you mentioned, when you know about what is the case posted tomorrow. So which instrument required for that particular surgery, so we should be prepared and we should check all the instrument for that particular case. If there is there is any problem, then we should communicate to the operating team that there is some problem, so accordingly they should be mentally prepared. Another thing, especially the vascular clamp. So you should ask the surgeon which instrument you would need. There are many surgeons have different preference for particular vascular clamp. Or again, in case of liver surgery, especially if there is large tumor which is located near the IVC, so always keep the thoracotomy set available, because sometimes there is a massive bleed near the suprahepatic IVC, then sometime we may need to do open the chest. So all these things should be something. Otherwise, it was a very good presentation.
Thank you, sir.
Good afternoon. I am Major Sumalata from Army Hospital RNR and liver transplant OT matron. Actually, very well presented. She has presented very well topic and in very precise way. Actually, in hepatic surgery, we should consider actually with WHO guideline, we should consider every patient as a infected patient. But in the liver surgeries, actually 30 to 50% patients are the infected patients. So we have to follow all the guidelines which is given to the WHO to protect ourselves and the team members. In you have told total hepatectomy. Total hepatectomy we will do only in the case of
liver transplant.
When we are going to do transplant, if we have a cadavers, we have taken the liver from the cadavers, or we are going to do living donor, we have a living donor, then only we will do the complete hepatectomy, otherwise partial hepatectomy we will doing. And in liver transplant, actually liver transplant in living cases, we are taking not full liver, we are remaining 30% of the liver inside the donor itself. Means 30% should be remain inside the donor patient, with the donor patient. We cannot take more than this. And as liver surgery is a very specialized, super specialized surgery, so all the super specialized instruments are required, as she has told, so many vascular clamps, Satinsky's, Cooley's clamp, vascular clamps, and we can say DeBakey's clamp. And the more important thing is we should not touch the artery. We should not touch the artery. It is the sin if we are touching the artery in the transplant, especially in the liver transplant. And she has presented very good topic, and further we will see the liver transplant, then we'll discuss all these things. And thank you so much.
Thank you, ma'am.
Also, I would like to add that we also need an ultrasound to see the vascular supply, and other thing, we should keep a liver biopsy needle to send a biopsy of the tumor and the normal margin. If it comes positive, the normal margin, then we have to extend our procedure up to some limit, so that the whole tumor margin should be removed and the normal area should be there. So I think these two things should be there in your mind. That the second one other thing I would like to follow, which we are not following, when we are assisting, there should be surgeon and the nurse. No one should stand in between. So the nurse should have a clear vision of the field and she can supply the things automatically. Because if one surgeon is standing in between, so she will look like surgeon जब तक नहीं पूछेगा, she will not be able to provide that thing. But if she is observing the field, she will supply everything, even the suture, cautery, everything she will handle like a surgeon. The other thing, Rochard and Thompson. Rochard is a little old kind of instrument retractor now, and the Thompson is now modern equipment which has come. So difference is nothing like that in that. But only thing, the manpower. If the surgery is 4 hours, 5 hours, surgeon cannot retract the give retraction for long time because it's very tiring. So manpower कम हो जाता है इसमें if we have a retractor. But surgery can be done without Thompson, without CUSA, without everything. Only you need bipolar and the monopolar cautery, which we are using. Sometimes we have 2-3 cases for the liver and we have one machine, so the other surgeon uses only bipolar and the cautery and the multi-load clips. Multi-load clips are very, very useful because time management, it lesser your time of applying clips, because every time you have to pass on another, it will take time. But when the surgeon is holding that multi-load, there will be a time management for that case. And you can better control immediately. The other thing is, you need a absorbable suture like Vicryl 20, it should be in your hand, because liver surgery, whenever there is a major bleed, we use it. And the argan is only used when there is we cannot control the bleeding, and it hemostates as a surface area. So I think this is the part I have to add, and we should follow all protocols like this only. Thank you very much. And Himani, you did a wonderful job. And Dr. Shuddha also, Samit Shuddha, he explained anatomically liver and liver lobe and its supply, and whatever he has to ligatures used for this, he has explained. Thank you very much.
Thank you, ma'am.
Audience?
If you have
Okay, sir.
Any query, any question from the audience side? Thank you.
Any questions for me?
To felicitate our speaker and panelists, I request Ma'am Isabella to come up, please, and Ma'am Hema. Dr. Samit, please.
Dr. Samit should.
हाँ, बीच में आ जाए. हिमानी, आप यहीं
क्या क्या लिखा है?
Dr. Kailash, please.
Dr. Kailash, चलिए please.
Major Suman Lata ma'am, please. मैम थोड़ा सा सेंटर में आइए. Dr. Kailash, I request you please stay with us as you are panelist in our talk 2. And for talk 2, which will be covering on pancreatic surgery, I request Dr. Karthik. Dr. Karthik, Nursing Officer Mansi, and Mr. Gopi from surgery block. Dr. Karthik, on the way. So, wait. As a panelist, we have Mr. Tilok from surgery OT. He is a senior nursing officer and well-known face, and Major Shisha, and Dr. Kailash again.
अभी क्या करना है?
डॉट के दास
करें? ठीक है आप
First of all, good evening to everyone. Now we are going to see about the pancreatic duodenectomy, also known as Whipple's procedure. When comes to the pancreas, we all know when comes to the pancreas. We'll start by later.
Very good evening, everybody. I am Dr. Karthik. So here we have gathered to discuss about Whipple's pancreaticoduodenectomy. So the first step is always we give a skin incision. In our department, we give a smaller incision to rule out any metastasis. After that, we give a bigger incision. Now, depending upon the physique of the patient, we can give either a midline incision or we can give a Makuchi incision, that is reverse L. So in this case, the importance of the nursing officer is that if we are giving midline incision, then they have to give us the self-retaining retractor, and if we are giving Makuchi incision, then they have to be ready with the reverse cutting to stitch the flap to the skin. After that, after ruling out the metastasis, we proceed to the first step. The first step is we mobilize the duodenum up to the left border of the aorta. In this step, we need, since we are working in depth, we need instruments that are longer, and we need energy sources like harmonic and ligashore. After that, we enter the lesser sac by opening the gastrocolic omentum. When we open this, we need energy sources like, as I said, harmonic and ligashore again. So the importance of nursing officer is that in this steps that they have to be ready with all the instruments and all the things that we need. Then after that, we proceed to taking the hepatic flexure down. Then we loop the intrapancreatic SMV. After that, we move to the portal dissection. We do the cholecystectomy. So in all these steps, the nursing officer should be aware of what all instruments we'll be needing the next. Right. After that, when we loop the vessels, all the major vessels around the porta, bile duct, portal vein, hepatic artery. So obviously the colored slings would be required, so that should be kept in mind. Then when we make the tunnel of love to lift the pancreatic neck from the major vessel, at that time the nurse should be aware of any risk of bleeding that can happen at that time. So all the vascular clamps, you should be ready with. And then we divide the specimen. For division, we need staplers like NTLC or Estelon. So that should be kept in mind. After that, we proceed to reconstruction. In reconstruction, since we use very, very finer sutures, and sometimes they get entangled, there may be a knot in the suture, that is very difficult to identify also. So here only the role of nursing officer comes, that they have to identify if the suture is not up to the mark, they should not give it to us. Because once we have taken the bite, we cannot undo it. That is true. We cannot undo that. After that, we proceed to the anastomosis. First is usually pancreaticojejunostomy, and then we do hepaticojejunostomy, where we connect the bile duct to the jejunum, and then we proceed to GJ. GJ is, I think, simpler anastomosis. The most difficult one is pancreaticojejunostomy. The second difficult is hepaticojejunostomy, and the third is obviously gastrojejunostomy. After that, we put drains, and then we close the abdomen. So this is in a nutshell of the overall steps of this thing, Whipple's pancreaticoduodenectomy, and the importance of nursing officers here. That's it.
Dr. Karthik has covered almost how the incision and how the dissection and how the closing it will be done. Now we'll start by the nursing management, the nurses how will assess for the Whipple's. Before going, when it comes to the pancreas, we all know about the pancreas have the major function. Pancreas have the endocrine and exocrine, they have a mixed function, and also it secretes the pancreatic juices that helps for the digestion. And then the major now currently affected, most of the people get diabetes, and the pharma industry also getting more developing for the insulin. the insulin is the secret from the pancreas. That also one of the major function of the pancreas. And when it comes to the question, why is it termed as Whipple's? Anyone knows why is it termed as Whipple's? Okay, I will tell the answer. Because the surgeon, American surgeon who discovered the first surgery, that Dr. Allen Oldfather Whipple's. So that is, it's termed as Whipple's procedure. When you, ectomy means, yes, ectomy means removal. The suffix there refers to removal. Pancreatic duodenectomy, we can easily identify the pancreas and the duodenum and the distal. Sorry for the inconvenience. Okay, sorry for the inconvenience once again. We'll start. Okay, I already told the ectomy means removal. The pancreatic duodenectomy involves removal of the pancreas. That's majorly they remove the pancreatic head and neck up to the body. Mostly they've done 50% of the pancreas they will remove, and then bile duct and the duodenum and the lower part of the gastric distal part. That's the pylorus. That's called pancreatic duodenectomy. The pancreatic resection is one of the most complicated because the pancreas is adjacent organs are the highly vascular like IVC, portal vein and renal vein that's adjacent to the pancreas. So when we are proceeding for the pancreatic duodenectomy, we have little careful because when they're using any organs, they should be blunt and fine. We should be more specific. The Alexander Covidi will have performed the first surgery. He is the Italian surgeon who discovered the first pancreatic duodenectomy. And I asked why it's termed as Whipple. The Whipples performed the first anatomic one-stage pancreatic duodenectomy for tumor of the head of the pancreas in 1940. Here you can see the image before the removing pancreatic duodenectomy and after removing. The major of the cancers are arising from the pancreatic head. That's, you can able to see the tumor. Okay, it's not working. So we can see before the surgery and after the surgery how what are the organs they removed and the anastomosis was done after the removal. The indications for pancreatic duodenectomy, the indication mostly depends upon the tumors which are arising from the pancreas and the duodenum. That's the types that the researches are done, the tumors mostly arising from the pancreatic head. There is a 70% of tumors are arising from the pancreatic head. And the ductal adenocarcinoma and neuroendocrine tumors and duodenal gastrointestinal tumors, and the intraductal papillary mucinous neoplasm and periampullary ductal carcinoma. These are the indications for pancreatic duodenectomy. And the preparation for the patient, we all know we have the basic history, past, present and medical history and past surgical history. And the lab evaluation include basic in blood investigation and the specific investigation for the pancreatic duodenectomy, the biopsy and then CT and PET CT. This shows the how much the cancer is spread to the adjacent organ. Based on that, the surgeons will plan to proceed the surgery, the resectable, unresectable. There are some gradings. We don't go in depth. And then tumor markers also is there, CA99 and CA carcinombrogenic antigen. And then the surgeon will discuss about, based on the radiographic findings, and then they will confirm the resectability. And then surgeon and surgeon team will discuss about the intra-op and post-op complications and the advantage different to the procedure to the patient and the patient relatives, and then they will get the consent. And then the anesthesia team also, they will see the patient, they will check the pre-anesthetic checkup, and then they will take the consent. And then as come nursing preparation for the patient. For OT, we have to do skin preparation. There is studies telling the skin preparation, we are nowadays, most of the areas they are doing shaving. That shaving is more prone to get the SSI to the patient, though WHO, they're recommending for hair clipping. And then WHO surgical safety checklist, and the antibiotic prophylaxis before incision of 30 minutes. And then deep vein thrombus prophylaxis for long surgeries. And then for invasive monitoring for like C line, A line, and then catheterization is also included. And then intubation was done for the under general anesthesia for further proceedings. And patient is placed on the supine position. This is the checklist. Already most of the people previously they have covered this also. In this they missed, after completing the checklist, the nursing team and the anesthesia team and the surgeon team, they should sign the checklist. There is required for signing. And this, some techniques, there's the open surgery there in the conventional surgery, open, this everyone knows. The advantages comes to laparoscopic, minimally invasive surgeries, and then laparoscopic assisted open surgery. The surgeon will first start with the laparoscopic, they will do some dissection, and then they convert to open. And then laparoscopic assisted robotic surgery, the advantages now, the innovations they're upcoming, they're doing the robotic also. And the incision is, SAR has covered already, I don't want to go this. Then some of the research findings have done, this is taken from the Lancet journal. There the evolution comes to robotics also in pancreatic duodenectomy also, the ongoing exploration you can see in the Lancet journal. And then they've done the comparison also, laparoscopic and robotic, how the post-op the patient is the complication or none. Now it's a time to give Miss Mansi, my friend, she will take care about the intra-op. Thank you.
Thank you, Dr. Karthik and Mr. Gopi for briefing us about the Whipple's procedure. So I would like, myself Mansi, working as nursing officer in surgery block OT. I would like to continue from here with the nursing management intraoperatively. Would like to, firstly, I would like to give you a brief about what we do in Whipple's. As everyone has already told, we have to remove some of the basic organs. Most common indication for the Whipple's procedure is the tumor in the head of the pancreas. So when the tumor is in the head of the pancreas, we have to remove the head of the pancreas, and we have to remove the duodenum part as well. Because when the tumor, because the duodenum and the head of the pancreas or the pancreas share the same blood supply. If the tumor is in the head of the pancreas, there are chances that duodenum will also get affected. So we have to remove the duodenum also. Similarly, if we are removing the duodenum, gallbladder needs to be removed too, as duodenum releases some enzymes which helps in the function of the gallbladder. If the duodenum is removed, gallbladder will not function normally, so we have to remove the gallbladder also. Similarly, we have to remove the gastric part of the stomach. It depends on the surgeon and it depends on the reports of the patient if they need to remove the gastric part or not. So when these parts are removed, we left with the stomach, a portion of the bile duct, tail of the pancreas and jejunum. We have to anastomose all of them to provide to prepare a connection between all these. And out of all these organs, only jejunum is the movable part. So we move the jejunum and do the anastomosis through the jejunum only. So what all the anastomosis we will do? First of all, there is the common bile duct which we will anastomose to the jejunum. So it will be called hepaticojejunostomy. And tail of the pancreas will be anastomosed to the jejunum, which is called pancreaticojejunostomy. And Similarly, gastric part or the stomach is the anastomosis with the jejunum, it will be called gastrojejunostomy. So these three are the main anastomosis we do in the Whipple's procedure. Next, these are some of the pictures of the specimens. If you can see, gallbladder, distal stomach, duodenum and tail of the pancreas are there. This is also a picture from the specimen. So when we comes to the nursing part, what we all require is some major or lab set we needs to be there for the basic instruments. Vascular set should be there, which includes vascular needle holders, vascular forceps for any vascularity. We need them. Hemolog set we should need. If there is any bleeding, we need hemolog set, LT applicators. Omnitractor or Rochard retractor or Thompson retractor is required because it is a long procedure and manual retraction is not possible for this. So we have Omni retractor or Rochard retractor or Thompson retractor for the retraction purpose. Dressing basin is also required. So here we have a picture of our trolley, how we prepare them. We have different instruments for the procedure. Like for the most important here, I would like to say is the is the right angle we use for the dissection. If we are doing the dissection of the pancreas, we should have a long and broad right angle for the dissection purpose. And we have to keep ready with the vascular instruments. Other special requirements includes feeding tube of all sizes. We need feeding tubes of all sizes to check the patency of the ducts, and we need slings also. Slings comes under the different colors like blue, red and yellow. Blue comes for the vein, red for artery, and yellow is one for the ducts, to identify the ducts. Slings are nothing but also called as vessel loops. These help in retracting the loops, retracting the ducts or the veins or arteries for the better vision for the surgeons. Similarly, rubber shots, as one of us already mentioned what rubber shot is. Umbilical tape is also used. Umbilical tape is nothing but a loop which we use like slings to retract the bigger vessels or for temporary ligature. Surgical staplers are required for the anastomosis, and for surgical staplers we go for echelon or NTLC staplers. Romovac or drains or JP drains are used for at the end of the surgeries. Similarly, some of the energy sources are also required. For the energy sources, we have monopolar cautery, and for monopolar cautery, it is very essential to place the earth pad on the patient to complete the circuit. If the circuit is not completed, monopolar cautery won't work. And similarly, we have bipolar cautery. It has two prongs, but bipolar, we don't need to put earth pad on the patient for the bipolar cautery because the circuit is already completed. For monopolar, we have to make sure that the patient is not attached to any metallic conduct, or earth pad should be there. A pacemaker should not be implanted. These points we have to keep in mind for when we are using monopolar cauteries. Harmonic bipolar leads are also frequently used. These are the pictures for the Romovac drain or Jackson pad drain. In Romovac drain, we put negative pressure and we place inside at this anosmotic site for to know post-operative there is any bleeding, or to maintain any intake output. We use Romovac drains or JP drains. Similarly, next comes the staplers. First one is the echelon stapler. It is more advanced stapler used for the anastomosis. It has 3 lines which cuts and coagulate at the same time. So the cartridges comes in different sizes and different color codings. Sizes we have available are like 60 mm, 45 mm and 35 mm. Color codings are according to the type of the tissue, like gray is for mesenteric or gastric tissues, white is for vascular tissues, specifically used for white is specifically used for vascular tissues only. Blue is standard, we can use then anywhere. Gold or green usually used for the thicker tissues. This is the picture of NTLC linear cutter stapler. It is used, abhi advanced mein we have echelon, so we don't use it much often. Echelon gun is more advanced. Echelon gun is more advanced as it has less locker technology. We have less manpower is required. So it is more advanced. So let me continue. Please pay attention. Please let me continue. This is how we use NTLC stapler in open surgeries. Echelons, another advantage for using echelon is we can use it in laparoscopic surgeries as well, but NTLC is not available for laparoscopic purpose. Some of the sutures we require, it completely depends upon the surgeon's choice and the availability in the institute. But some of the common sutures we have to keep ready includes a Proline for 6050 or 40, as already have mentioned that 6050 Proline should be given in the vascular needle holders or long needle holders because it needs to be go in depth. Similarly, we have to keep ready for the PDS, Etrosilk, Vicryl, as ma'am have already mentioned. Then Vicryl is required. Vicryl is needed if there is any bleeding, any chances of the bleeding. Vicryl needs to be handheld. Pseudopacks are required. Pseudopacks, one of us have already mentioned that pseudopacks are required for the tying the knot, tying the vessels. Liger clips and hemolocks are also used, and for the closure we use loop nylon, 3-0 nylon, monocryl, depends upon the surgeon and the anosmosis done. So these are the LT clips and hemolocks. I would like to mention some few points about the LT clips and hemolocks. LT clips we have made up of titanium, as we all know. It was used earlier, but nowadays we prefer hemolocks. Why? Because hemolock has a locking mechanism which LT clips does not have. LT clips are placed inside the patient body and we don't remove them. And but there are chances if there comes any swelling or so it can come out. But hemolock have locking mechanism. We will get a click sound when we apply the hemolock to know if it is applied correctly or not. So here's the benefit of using hemolock over LT clips. So when we have done all Whipple's procedure, we have discussed what we all have to do, what is required. Next comes when we have everything is removed, a tube is placed in the jejunum for the feeding purpose. Because for the healing purpose of the patient, we have to keep the gastric outlet empty for few days of the patient, which depends on the healing of the patient. So for the healing purpose, we do feeding jejunostomy. Feeding jejunostomy is nothing but a Ryle's tube or tube is placed in the proximal part of the jejunum, which is the primary function of is to give the nutrition. For that we do the feeding jejunostomy. So this was all I wanted to share with you. Hope you liked it. Hope you got anything. Any questions from your side? Any questions? Thank you.
Thank you, Mansi and Gopi, for a nice overview. So, as we know, Whipple or pancreatodonectomy is one of the major and complex GI surgery, and it also takes lots of time, maybe at least on an average 6 to 7, sometimes 10 to 12 hours. So, there are few important things I want to tell. One thing, you always keep the suture on open on table at least 3 or 4 or 5 of Proline. There, because of if the bleed is occur, you immediately don't ask to somebody open and then give some time, there may be no body on the floor. So always keep the suture open, at least one each 1, 3 or 4 or 5 of prolene. Second thing, this is a major surgery, so and for prolonged duration. So the patient, there is in these surgery there is a chances of patient went into hypothermia till the end of surgery. So always use the warm saline in between whenever you change the saline frequently. Third important thing which I follow and I tell my resident, before start the reconstruction, at least you do small gauge count, because once you do the anastomosis and in end if you don't found, it is very difficult to check, because if we try to manipulate the anastomosis and pancreatic, we know the pancreatic is one of the most crucial anastomosis. If we try to manipulate to search the gauge, then it may lead to difficulty and disrupt the anastomosis. So make a habit, at least sponge it will not go behind the anastomosis, but at least small gauge always check before the reconstruction start. This is one of the important.
One fourth thing I added, dilator. If supposed to surgeon cut this pancreas, this very thin or narrowing part of the duct cannot do the anastomosis. So you need to have probe, different size probe we having noticed. No?
Watson chain.
In Watson chain also, na? Means our concern surgeon concern is dilate the part. So you keep ready with the probe, Watson chain detector or yes. इसके अलावा you have to count 3 times whether you are needles, sponge or tail gauze, because when we are starting the dissection ना, the tail gauze should be come, I don't know कहाँ घुस गया वो सर्जन को भी नहीं पता, ठीक है. फिर after that 6 hours सर नहीं है तो सर्जन को भी नहीं पता कि यार वो कहाँ चला गया. तो at least ना 3 times before you giving, you are in the trolley, after discard 3 times you should count it. So 6 hours, 7 hours, 8 hours लॉन्ग प्रोसीजर. एक बार प्रॉब्लम हुआ उसके बाद रेक्टिफाई करते रहो अल्टीमेटली पेशेंट सफ़र. सो ये सब चीज़ भी इसमें ऐड करना है बस. थैंक यू. गुड.
Good morning everyone. I am Major Sirisha. I am OT matron from RR and I am also liver transplant trained. Thank you speakers, very knowledgeable presentation. Like few things I want to emphasize. I am sure you must be already practicing. When we give rubber shots, especially in hepatococcygeostomy, like what we practice is the corner shots we give on curved artery with a different color.
That also we do. We also do the same.
You must be practicing. I just want to emphasize, since it's
Right.
we are from a different setup.
We don't have this.
And generally that metallic suction do we use, like if we use, it's wiser to put a rubber shot even on that.
We are using the practices we.
That's what I said. I just want to emphasize you must be definitely practicing it. And lubrication of sutures, I just want to know from you, like how do you do with
No, what some company person is telling is already suture is antibiotic and coated to just in saline soap and
silk also you put it in saline?
And silk, this is the in fact
like what we use is paraffin gauze.
Yeah, you can use.
We can use paraffin gauze even sterile.
Paraffin gauze or liquid paraffin, which is sterile.
Okay.
And most of our surgeons, they work under loop on. So like ma'am said, there should be no one in between surgeon and matron, scrub nurse.
Yes.
So it's better you give, like they have to again orient themselves to that field again if we don't give instruments in hand. So that is very important for a scrub nurse. If you don't see the surgery, if you don't see the steps, you will not be able to assist, because with loop it's actually very difficult. They have a very limited scope of seeing things. And as sir discussed, like hypothermia is one thing, and especially in liver transplant surgeries, we drape patient in 3 layers to prevent hypothermia with properly sealed from sides. Even this is a longer surgery, so we do take care of those drapes also.
Yes,
And
we do use bare haggers to keep the patient warm.
yes, ma'am. Other
Yeah.
than that,
Other
like we
than
seal
we
from
put
sides
double
also.
drapings.
Yes,
One
ma'am.
with the linen, one is with the linen, and the top one is with the
3
disposable.
layers we are
one.
using the draping.
Yes,
Small size and long size.
And ma'am, we use also magnetic pad at foot end, like where we are working, so that those energy devices which become, so it like surgeon is in hurry, bowl is here, and we are standing. He will just keep harmonic on that. It happens.
Yes,
So
yes.
we generally put magnetic sheet so that drape also doesn't get burnt, and bowl is also protected.
मंगा लो मैडम.
So
अच्छा suggestion है.
One thing I would like to add on, as Mr. Trilok, senior nursing officer, said that when surgeon is unable to find out the duct, because pancreatic duct, it is too small. And many times the surgeon asks for a very small micro dilators. If feeding tube is not, 5 number is not used, then the Watson chain, if other than the micro, then we come to the micro probes to find out the duct. But even then, if we are unable to find, surgeon is unable to find a duct, then what he will do? He will do directly pancreas to the jejunum, pancreatico-jejunostomy. Direct pancreas को ही jejunum के साथ जोड़ देना, rather than finding a duct. So that procedure is called dunking procedure. So many times Dr. Sujoy does this, and he is very regularly he is doing this thing.
You need eye needle.
Eye needle.
Many surgeon, our surgeon asks for eye needle to pass on the suture like this and this. So this is how the dunkling procedure is used.
Thank you.
thank you, ma'am.
One more thing, nowadays we are doing more complex surgery and also doing the vascular resection. So most of the time we able to do primary repair, end-to-end anastomy in portal vein. But sometimes we need the graft if the defect is long.
Yes.
So always keep the appropriate size of graft in the OT, because now we are doing regularly complex Whipple surgery.
Sir, one more thing.
It's not available, which is very expensive and not available, and whenever we want it urgently, then we can harvest the vessel also for that.
Sir, one more thing I want to ask, as moderator said that if a patient has metallic rod or pacemaker in her or his body, and then we should not use the monopolar cautery. So what are the other options to on that patient?
One thing, in pacemaker we mostly change the mode just before surgery, so it will not lead problem.
Okay.
Otherwise, rest of the thing except monopolar, we can use other thing, harmonic, everything.
So then monopolar cautery is strictly prohibited in that patient.
Definitely, but we change the mode before the surgery, the pacemaker change. Otherwise, rest of the metallic thing don't.
Okay. Only pacemaker is the.
In pacemaker
Yes,
there is different mode change करके monopolar use कर सकते हैं. Otherwise जिसमें circuit complete होता तो bipolar है, अपना harmonic है, ये Ligas हो रहा है, ये सब use.
That we can use, but I am asking about monopolar cautery only.
No monopolar.
Yeah.
और उसकी arrhythmia में कोई history है तो नहीं कर सकते.
Okay, thank you, sir. Thank you.
Pacemaker का mode change.
वो आता है ना बुलाते हैं.
प्रयोग करते हैं वो वार्ड में कर देते हैं, वो ओटी में पता नहीं लगता, वार्ड में होता है, बाद में फिर चेंज करते हैं वो स्टॉप. ठीक है.
ठीक है. Good Mansi, but efficient nurse always think surgeon's mind. No surgeon ask sister ये दे दो क्या ना, you have to think. वो हाथ करे, उसकी palm पे sound आए सर ये लो. Yeah, this is the.
इसीलिए जैसे आपने बताया ना कि स्टेप्स ऑफ सर्जरी, यू शुड नो द स्टेप ऑफ सर्जरी एंड व्हाट शुड बी द नेक्स्ट स्टेप. So that's why you will be prepared if you know about the procedure and what is the next step. Especially as I told, during the bleeding, that time when the stress level is go up.
And your stress also, मतलब अब you making the stress, you cannot perform your work. So just relax.
So Trilok ji is trying to say कि a nurse should have a संभाव वाली स्थिति, empathy वाला. कि उसको ये लगना चाहिए कि मैं डॉक्टर की जगह हूँ तो मुझे क्या क्या
Very
चाहिए, तो वो समभाव एम्पैथी वी ऑलवेज ट्राई टू फोकस.
ये लोग ये तो ज़्यादा हो गया.
So we should call him Dr. Trilok from now on.
हाथ से पकड़ा आईवीसी को इसने, सर्जन से नहीं पकड़ा गया जल्दी से, but he holded it the hand and then surgeon put a clamp. So that we are proud of him because of his knowledge. इन कौन सा लगाया था आपने ग्राफ?
वो उसके लिए बनाओ पेरिकार्डियम करके उसी के ऊपर
पेरिकार्डियल ग्राफ किसी सर्जन से
पेशेंट मर रहा है
सीटीवीएस की वेट कर रहे थे कि दे विल कम एंड टेक अ पेरिकार्डियल ग्राफ,
That's why
but
team-
he was
team
there,
approach.
he
This is
taught
the
the
team approach,
surgeon
na?
how to take a pericardial graft and he helped him and surgeon did
Dr.
it
Sujoy
before
थे,
the
वो बिल्कुल
CTVS
ही
surgeon
क्या
came
करें?
because
ले
of his
यार,
help and they all clapped for him that your इसकी जगह जो है एक सर्जन की जगह है.
So he is literally an unsung hero. So to now I request Vishnu ji and Dayanand ji to come up for the felicitation of our speakers and panelists. Mr. Vishnu, Mr. Dayanand, and Deepak Soni too, junior. He can also join. Junior. जूनियर है ना ये. हाँ प्लीज आई रिक्वेस्ट डॉक्टर कार्तिक प्लीज. मानसी, आगे से मिस्टर गोपी, हाई एनर्जी, मिस्टर मेजर शीर्षा, डॉक्टर कैलाश आई थिंक हो गए डन ना. So thank you Dr. Kailash, Mr. Trilok ji for enlightening us with your deep knowledge. Now let's move forward to talk number 3, which will be focusing liver transplant surgery. We have Urvashi, Dr. Urvashi. Okay, Madam Urvashi we have as a speaker, and in our panel we have Dr. Kailash again, Madam Sunaina, and CB Agarwal ji from Medanta Hospital. CB Agarwal, please. Okay, please.
Good afternoon everyone, this side Urvashi, Nursing Officer Main Operation Theatre, AIIMS New Delhi. I will be discussing operative theatre nursing management of cadaveric and liver donor liver transplant. It is a very wide topic, so I will be very precise. So let's start with the definition. A liver transplant is a surgery that removes a liver that no longer functions properly and replaces with a healthy liver from a deceased donor or a portion of a healthy liver from a living donor. These are the indications of liver transplant. Types of liver transplant are living donor transplantation, cadaveric transplantation. This is an overview of transplantation procedure for the patient and for the donor. Cadaveric liver transplant or diseased donor liver transplant is a procedure initiating transplant of liver harvested from a brain dead person with the consent from his immediate family members. Operation theatre management for diseased donor liver transplant. As soon as we receive the information regarding a DDLT, we need to prepare the following things. All the sets that we require for the surgery needs to be double autoclave. We should ensure that all the sets should be sent to CSR. with the proper label of double autoclaved. The sets we use in our hospital are LTP donor set, LTP donor perfusion basin, cut down set, LTP ice crusher, a donor bag kit that we made for our help, and ice, energy sources, and custodial solution. This is a basic, LTP donor set is a basic laparotomy surgical set that we have already discussed. The cut down set and the ice we use is normal saline. This is the ice crusher that we use for the perfusion purpose. And this is a short video how do we prepare the ice crushed. The energy sources that we have is harmonic, monopolar, bipolar machines. This is the custodial solution that we use for the perfusion. Donor bag kits. Donor bag kits, it is not something that every hospital must be using, but we use in our setup. It is for our help only. We made a pre-kit type of a thing ready that contains all the general items that we need in a surgery, and the special things that we need is organ bags, the energy sources, tubings like suctions, IFTs, drains, etc. Slings, the use of slings, LTs has already been discussed, so I am not be discussing that. Hemostatic agents and the general items. The cadaver donor table setup. In our hospital, we do the cadaver thing in trauma center AIMS. So this is a visual representation. How do we prepare? This is our main working trolley. That's for the linen trolley, and that's basin stand. And one trolley for ice crusher. There. Did you see that ice crusher trolley? Perfusion or benching of retrieved liver. Bench surgery allows the recipient surgeon to evaluate and prepare the liver for implantation and to deal with the potential injuries that might have occurred during the retrieval process in order to ensure successful transplantation. And the preparation of OT for benching is, we need recipient benching set, ice crusher, custodial solution, fine sutures like 4O, 5O-proline, fine suturepex like 3O, 4O, silk, weighing machine. Our recipient benching basin set consists of 2 basin, hammer, fine mosquitoes, fine needle holders for 4 or 5 proline, fine scissors like Iris, Reynolds, fine meds, vascular forceps, and the metallic cannula that we use for the perfusion purpose, and the dilators you can see, metallic dilators. Perfusion or benching setup that we make in our OT, a table with ice crusher for preparing the ice, one table for all the instruments, and a main table for organ perfusion with the perfusion solution hanged along. Alongside, the 2 surgeons will be sitting or standing, and they'll do the perfusion. Note, the perfusion is done at 2 times in case of cadaveric, that is at the time of retrieval and before the transplantation at the recipient side. Now, the living donor liver transplantation or a living donor liver transplant is a surgery in which a portion of the liver from a healthy living person is removed and placed into someone whose liver is no longer working properly. The donor's remaining liver regrows and returns to its normal size, volume and capacity within a couple of months after the surgery. At the same time, the transplanted liver portion grows and restores normal liver function in the recipient. Operation theatre management for living donor. Living donor is an elective or planned surgery, so we keep 2 OTs ready, one for the live donor and another for the recipient, and one benching area prepared. It is a simultaneous surgery, so 2 teams are working in coordination. First OT for live donor. Preparation is same as the hepatectomy surgery. I will not go in deep because hepatectomy already been discussed. All the sets needs to be double, we must ensure that all the sets needs to be double autoclaved, all the linen that we are using needs to be double autoclaved, and all the basic thing that requires in a surgery, in a laparotomy surgery. Special consideration is CUSA, and we use in our hospital is a bipolar with suction, the vascular set and the microvascular set. Operation theatre management for recipient. The necessary equipments are, I think, already been discussed, like diathermy machine for the patient warming devices and DVT pump, pressure gel pads, rapid fluid infusion system, thromboelastogram, etc. The necessary instruments that for the recipient is LTP recipient set, LTP recipient basin, Thomson retractor set, vascular set, microvascular set, cut down set, and other chittle and miscellaneous drum, and the general items, of course. Thomson retractor, this is a visual representation of Thomson retractor. Our recipient vascular set is this one, in which we have the fine vascular forceps, vascular needle holders, the dilators, the clamps, the bulldogs. That one is Satinsky clamp, Cooley clamp, bulldog clamps, and DeBakey clamp. According to the choice of surgeon, we can use that. Sorry. This is the picture of microvascular set, which have microsurgery forceps tweezers, micro scissors straight and curved, bulldogs, and Castrovigo for 7O, 8O prolines. This is the visual. This is just a picture of our recipient table setup. We have a main Mayo stand, working trolley, and all the trolleys for remaining sets. Now the liver transplant operation. The sequence of the event in the operating room is as follows. Receiving of the patient in the OT. Following the identification, we must ensure the consent. If in the case of living donor transplantation, we ensure that the consent and the relation of the donor and the recipient, and all the identification that already been discussed, WHO checklist should be followed. The position of the recipient is supine, dorsal recumbent, and after cleaning and draping, the incision is bilateral subcostal incision with upper midline extension, that is called Mercedes incision, or extended subcostal incision with upper midline extension, J-axis or hockey stick. And in pediatric patient, we take the bilateral subcostal. The second step is evaluation of the abdomen for abnormalities that would preclude liver transplantation, for example, undiagnosed infection or malignancy. Third one is mobilization of the native liver, dissection of the liver attachments to the abdominal cavity. Fourth one is isolation of important structure, the inferior vena cava, behind and below the liver, the portal vein, the common bile duct, the hepatic artery. Fifth one is transaction of the above mentioned structure and removal of the native diseased liver. The main step is the swing in the new liver. The three important anastomosis are, first one is the venous blood flow is re-established by connecting the donors and recipients inferior vena cava and portal veins. Second one is arterial flow is re-established by swinging the donors and recipients' hepatic arteries. Finally, the biliary drainage is achieved by swinging the donors and recipients' common bile ducts. Then ensuring the adequate control of bleeding, closure of the incision. This is a picture of a healthy liver. The red one is the hepatic artery and the blue one is the portal vein. This is a recipient explanted liver. Donor resected right lobe of liver. Resected liver after implanted to the recipient. This is a cadaveric liver. And cadaveric liver after implantation. Now the responsibility of scrub nurse that we have discussed, I'll just combine, must be a registered nurse, should ensure surgeons need and should know all the anatomy and physiology and all the steps according to the procedure, should be responsible of the counts of sponges, tail gauze, needles, etc. And should monitor the sterility, that's the basic and most important thing, and keep tracks of irrigation for the blood loss. The responsibilities of circulatory nurses should be responsible of should be performing WHO checklist and should be responsible and accountable for all the activities occurring during a surgical process, including the equipment, supplies, and the environment during a surgery. We should take home a message. Effective nursing practice or care and management of expected complication can provide an excellent outcome in liver transplant patients. Thank you.
Good evening, everyone. My name is C.V. Agrawal from Paras Hospital. Most of the thing covered by the sister. Something I want to share with you. When we do vascular anastomosis, we should clean all instrument, decloth instrument, because the vascular anastomosis is very precious. If we didn't clean any instruments, then clotted part entered in the vascular anastomosis, so thrombosis can be happen in this. Or while doing preparation the OT, so there is so many troubleshoot things should be available in the OT, like vascular grafts all sizes, cryopreserved veins, arteries, and some more things like amblectomies, snugger set, and biliary stents. So we can manage every emergency, unwelcomed emergencies in the case. We should be one step ahead the regular process. Thank you so much.
Thank you, Urvashi. So again, most of the thing discussed in each and every section. So and in last is also key during handling of SAR. So again, these are most of the transplant patients are infective case. So not during giving to the surgeon, while taking back also you take the sharp, all sharp in the kidney tray. No, never is used in the hand. And again, I many times see and I tells when you use the that Romovac drain, so the cap of that should not be handled by the hand. You can take this by the maybe one artery and during also apply with by the artery, not by the hand. This is the very sometimes it may lead to a very danger. Okay, thank you.
Thank you, Urvashi, for wonderful presentation. I would like to elaborate, sir, things like that. Most of the liver transplant patients are positive, like HBsAg and hepatitis B. So we used specified drape for that, and we used disposable drape. And that thing I think we can add on this, that because we discard all the drapes after that and take care of the sharps, as he said. And one more thing, that how to handle the harvested liver. When we get the call, in cadaver we got a call from surgeons that we had a transplant, so liver is somewhere else. So how to handle that thing? Most of the part take care by the surgeons, so but we also should take care of this, that when it reaches to us, how we can keep it, where we can keep it. It should be always kept in sterile area, and when we open it, just wear the gown and gloves, proper gloving and gowning, so we can open it in a very sterile manner. So because this is very sterile procedure like all the other procedure, but we should take extra care in liver transplant. And the other thing, I think as sir mentioned in Whipple's also, that we should count the small tail gauzes, needles just before, specifically in artery and osmosis, because there is no chance to touch the artery and osmosis again and again to find out the needles and tail gauze, etc. So we should keep in mind all these things, that we should do this all just before the artery and osmosis. And I think that's all. If someone asks something, that he can.
Hello. What is the logic behind double autoclave? Once it's autoclaved, it's sterile now. Then why double autoclave?
For more sterility.
There is no more sterility.
But
Once it's sterile, it is sterile now.
But
is
we
no-
should be more vigilant because it is a more cautious.
Actually, I would like to answer then. It's enough to sterile in one time, but I think in transplant, any organ, in transplant, we don't want to take any chance that by mistake any instrument or any sets kept behind the thing. So it should be better that we can do it in double autoclave. So we
Okay,
can get the 100% surety that it's sterile. So
Okay, okay,
you
thank
can
you.
see in OT that we some things we used in single autoclave also, in plasma also, because they are surely autoclaved. So that's the reason I think we used it double autoclave. For double assurance to keep the double protection.
Bas? Okay, if you have any query, please feel free to ask. There is no query? Okay, so now I request Mr. Madan, Mr. Sanu and Miss Himani to come up please for felicitation. नुकसान हो गया तो. So I request my our speaker Urvashi. To felicitate Urvashi ma'am, I request Mr. Sunoop and Mr. Madan. Please hand over.
Dr. Rajesh का
Photo.
या
मैडम
वो
सुनैना,
सौरभ,
उनका भी है विचार में कुछ
हिमानी जी, मिस हिमानी, हो गया? नहीं देना है. Mr. C.B. Agarwal जी, Mr. C.B. Agarwal जी. Okay, we would also like to mention about C.B. Agarwal ji. He is in Paras Hospital and is very active member of liver transplant unit working over there. So many thanks from the organizing team to be here and share your knowledge with us. Thank you, sir. And for our next session, we have Lieutenant Colonel Dr. Amit Kumar Singh. We can easily recognize through his uniform, and it is a pride. It is a proud moment for us. He is a GI surgery. He is a GI surgeon in Army RR Hospital, New Delhi. And as a panelist, we have as a second speaker we have Miss Vaishnavi Bharti, nursing officer AIMS. And in our panel we have Dr. Rajesh Pawar. I think he has an. Okay, Dr. Saurav is coming, Dr. Vignesh is also there in our list, Dr. Vignesh, and Nargis ma'am again, and Miss Shelly. Shelly, okay, so. Major, okay, Major Rashmi, please. Please.
Good afternoon, everyone. Possibly now becoming evening here. When I was approached for this talk, I really was not able to make up my mind what I should be speaking here, because I am sure every one of you has been working for a long period and you all are very well versed with whatever is going on here. It is just a revision for everyone, and I would just briefly introduce to you about colorectal surgeries. And from the introduction onwards, I believe Vaishnavi ma'am is going to take over. See, colorectal surgeries generally they encompass the whole of colon, rectum, and some diseases which involve both the colon as well as the small bowel. So it also encompasses all kinds of benign disorders as well as malignant disorders. Also, it encompasses emergencies as well as elective surgeries. We should also remember that the approaches that will determine the patient's position, the instruments that will be used, whether laparoscopic or open,
the approaches are also quite different. Not just abdominal and open approach, but also laparoscopic, now robotic as well as perineal approaches. In benign rectal disorders, mostly the lithotomy position is used, and mostly the instruments, most of us are well versed with those instruments, except for certain instruments which might or might not be available, like Lone Star retractor as well, and hemorrhoidopexy guns and all. But those are basically for the benign disorders. When we come to the malignant disorders of colon and rectum, the open approach is now being taken over by the laparoscopic approach, and in pelvic surgeries, it is now the robotic which is coming up in a big way. In rectal cancers, we have both kind of approach, open as well as lap, in which we generally go for a low anterior resection or an ultra low anterior resection or an abdominoperineal resection. Depending on whether the cancer is involving or is very close to the internal sphincter, and intersphincteric resection can also be done. The primary aim of any elective malignancy of colorectum is to achieve the oncological goals of resection, of getting a R0 resection. Second being the anastomosis, and third is to improve the quality of life of that patient as much as possible. So all our surgeries revolve around this thing. In emergencies, the main issue is to cruise over that physiological response of the patient to that particular emergency, which can be in form of intestinal obstructions or it can be in form of bleeding. So in such cases, generally the surgeries are only to cruise over that physiological emergency, and the elective surgery can be taken undertaken after at a later date when the patient physiology has settled. In such cases, we need to form stomas. They can be either colostomies or they can be ileostomies. They can be end stomas, they can also be loop stomas. Then coming to anastomotic procedures, there are many ways. It can be an ileocolic anastomosis, it can be a coloanal anastomosis, and in some cases it can be just a colocolic anastomosis, depending on the type of disease that we are dealing with. I think थोड़ा सा heavy मैं बता चुका हूँ. मतलब the basic thing that you should be well versed will be covered by Vaishnavi ma'am. So she will be covering that, and I hope it will be a good presentation. I have seen the presentation, it is very good. And if there is any doubt, I am ready to answer the questions. Over to Vaishnavi ma'am. Thank you.
Thank you, sir. I'm Vaishnavi, Nursing Officer, AIMS Delhi. I hope everyone is not tired. So we'll begin with the last presentation now. So we'll be discussing now the operative theatre management for colorectal surgeries. So what are colorectal surgeries? Sir has very well explained what are colorectal surgeries. So the surgeries that I will be discussing in this presentation. Ma'am, PPT. Okay, so the surgeries that are included in this presentation are APR, LAR, IPAA, hemicolectomy and colostomy. So the first surgery is the abdominoperineal resection. So predominantly this is used to treat a low-lying rectal carcinoma by removing the sigmoid colon, rectum and anus, leaving behind a permanent colostomy. As you can see in this picture, there is a low-lying rectal carcinoma. It has been resected and a permanent colostomy has been placed. So sigmoid colon, descending colon and the upper rectum is mobilized perabdominally. So there are two incisions. One is perabdominally and the second incision is made through the anal canal. So anal canal with perianal and perirectal tissues are dissected per anally. So the retained colon is then brought out as an end colostomy in the left iliac fossa. The next surgery is LAR or low anterior resection. You can see LAR is resection of the rectum below the peritoneal reflection along with the sigmoid colon with total mesorectal excision through abdominal approach, and colorectal anastomosis using a circular stapler device, the EEA stapler, which is end-to-end anastomosis stapler. As you can see in this picture, the highlighted portion is the carcinoma. It is removed during the surgery and the rest is anastomosed. The next surgery is IPAA, ileal pouch anal anastomosis. So this is a surgery performed to restore gastrointestinal continuity after surgical removal of colon and rectum. So this procedure involves creation of a pouch of small intestine to create the removed colon. So as you can see, different pouches are used after restorative proctocolectomy and during ileoanal anastomosis. This pouch acts as a reservoir and it reduces the frequency of the stool. As you can see here, there are 4 types of pouches: the J type, S type, W type and the H type. The J type is the most commonly used pouch. Next, a hemicolectomy. A hemicolectomy is basically a colectomy procedure to remove one side of the colon. So in this picture, I have shown a right hemicolectomy. The right ascending colon has been removed and it is attached to the small intestine. So after a lot of these procedures, a colostomy is made. So a colostomy is an artificial opening made in the colon to exterior skin to divert the feces and flatus. So there are 3 types of stomas that I have depicted here. One is a loop stoma, second is a double barrel stoma, and third is the terminal stoma. So before we begin the intraoperative position, the patient is placed in a lithotomy position for the surgery. This is a depiction of a lithotomy procedure. You can see the surgeon and the assistants and the scrub nurse beside them with the trolley for their instruments. So this is how a lithotomy position looks like in ROT after the patient is draped before the incision. Another thing is that for hemicolectomy cases, we mostly use the supine position. And another position known as supine leg straight split position is used for cases like laparoscopic assisted LAR. So in this position, as you can see, the knees of the patient, they are not flexed. They are straight and the patient is placed in a legs apart position. So trolley, as we've already discussed before, this is a basic laparotomy trolley that everyone has discussed. We use similar instruments. We use a major set, we use a vascular set, similar instruments are used. So retractor is also similar. We use a Zernes, Morris, Harrington and a bladder. This is the bladder retractor that we use in our OT. This is very important to prevent any injury to the bladder during surgery. So special requirements. These type of surgeries, they require some extra instruments and equipments that are not used in other surgeries, such as a surgeon's tray, a surgeon's chair, sizers, proctoscopes, GI staplers, such as NTLC, curved stapler, circular stapler, D-Martel, Wolfson, intestinal clamps, some intestinal clamps and anterior resection clamps. So a surgeon's tray. This is a surgeon's tray. This is a basic metallic surgeon's tray that we drape and place instruments. Okay, so now can anyone tell why do we use a surgeon's tray? Yes, so this tray is passed on to the surgeon for ease so that the surgeon can easily, yeah. Next is surgeon's chair. This surgeon's chair is used while perineal resections are being performed. This is a surgeon's tray without the draping and then we drape it to maintain sterility during the procedure. Next are sizers. So a sizer is used to predetermine the size of EEA stapler to be used. So this instrument is introduced transanally until it reaches the tip of the rectal stump, previously closed with a linearly stapled line. So as you can see, it is available in sizes 27, 29, 31, 33 mm in our OT. So we introduce this rectally and we can check what size of EAA stapler, that is a circular stapler that can be used for the surgery. Next is the proctoscope. This proctoscope is used for visualization. You can see the obturator and the proctoscope sheath. Next is the D-Martel Wolfson intestinal clamp. So this clamp is available in our GIOT in the intestinal set. So it can be used for intestinal walls, omentum, blood vessels. This was earlier used when staplers like Contour and CDH were not very widely available. Next, intestinal clamps. We have these intestinal clamps in all of our sets, the curved and the straight clamps. They can be applied on intestines. So they are available with a smooth edge or a serrated edge according to the need. Next, these are anterior resection clamps. They are also LAR clamps. They are also used sometimes in the surgeries, though rarely used, but they are also used in these cases. Next is a linear stapler. We have already discussed there are two sizes, 75 and 55 mm. This picture is of a 75 mm NTSC gun. Next is a curved stapler or a contour stapler. Okay, so before I begin these two staplers, I would advise that there is a stall for Johnson & Johnson on the ground floor, and they have displayed the curved stapler and the circular stapler. I would recommend that all of you please go and check out the staplers for yourself after this presentation is over. So the contour stapler is available in following sizes, 45 green and 45 blue. So this image shown here is of 45 green, and you can see how it is applied. So the next is the circular stapler, CDH stapler, or we've been calling it an end-to-end anastomosis stapler. So this stapler is available in 29, 31 and 33 mm sizes. This picture that I've shown here is a CDH 33. So how do we use this? So basically this, for us we can remove the anvil of the stapler and the shaft of the stapler. So this anvil of the stapler, it is inserted in the lumen of the colon perabdominally. So when we give this anvil to the surgeon, we give it and we give a proline suture so that they can create a purse string suture. As you can see here, this is how the purse string suture can be used. So after the purse string suture is tightened, it looks something like this. So after this has been done, so what we do is we introduce the shaft of the CDH stapler. We apply some jelly for easy lubrication just on the brim of the stapler, so as not to occlude any stapler pins, just at the edge so that it is easier for us to insert. So after it's inserted, it's fixed as such. As you can see in this picture, you can see the ileal pouch, you can see the stapler, and you can see the muscles, the levator ani. And after it's fixed, the stapler is fired and it's gently removed through the rectum by moving it back and forth. So after firing the stapler, it is ensured that, as you can see here, the donuts are being removed with the help of a forceps. So these donuts, they are removed with forceps very carefully, and they are inspected that all of the tissue layers are removed with the donuts. There are two donuts, the proximal donut and the distal donut. So if there is any breach in the donut, we should inform the surgeon that the donut is not intact and we should reconsider. Because if there is misfiring of the stapler, it can lead to leakage. It can cause, basically it will not be a successful firing and it will not be feasible. So energies, this is how it's basically done. This is the end of the CDH stapler. Energy sources, we use the same, the monopolar cautery, the extendable cautery, bipolar cautery, harmonic. So harmonic, we use the long probe because we need to work in depth, so we prefer a long probe. So now after all of this, there are some special considerations that I would like to emphasize. So while placing the patient in the lithotomy position, it must be ensured that all the pressure points are adequately supported to avoid any injury. It's a long surgery. We don't want the patient to have any injury, so we make sure that the patient is placed in a comfortable position for the lithotomy. So, and this is very important, the instruments used for the perineum should not be mixed with the abdominal instruments to prevent any cross-contamination. We don't want the abdominal side to get infected. So that's why. And the last point, very important, the donuts, the proximal and the distal, after firing the stapler, should be inspected for continuity, or it should be confirmed that both are complete. And if not, the surgeon must be informed. This is very important. With this, we come to an end. Thank you for paying attention.
Thank you, Vaishnavi. Anyone ask to any questions? So.
explained everything so well. Only whenever any intestinal part or the colon is cut, you should use some pledgets to clean this thing to prevent infection. And all the small pledgets should be counted and taken back. And whatever, if you are using the instrument to take out the dirty pledgets, that instrument should be discarded or kept separately and should not be used on the abdominal wall or some other area to not to get it infected. Otherwise, there are complications of leakage after the anastomosis, and that actually surgeon has to see. And our part is we have to check the donut, and if it is not intact, then we have to inform the surgeon, and surgeon will see either the misfiring. And many times it happens, after your stapler doesn't work out. Now we have a battery operated circular stapler, and sometimes we know how to use it, but sometimes it is misfired. And there is another reason, we should keep 29, 33, both the staplers ready, because sometimes the 33 doesn't enter, or the surgeon has to measure with the sizes, so that he can choose correct CDH stapler which is to be used. So it has happened that 33 has not gone, then the 29 is being used, opened and used, and these disposals are very, very expensive, so we must use judicially, so that I think that will add an extra burden on the hospital if we are doing such mistakes again and again. So we have to be very careful for using all these instruments. So thank you. That's what I have to say. And I'll ask Dr. Vignesh to add on something if he wants. One thing I would like to say, recently there was a leak. Then again, a resident asked me to TS stapler 60, arrange TS stapler 60, and we applied and we blocked the lower part, and we made a stoma for it, because otherwise the patient will get impact. Thank you.
Very good presentation, Sister Ji. From our point of view, surgeon's point of view, the most important thing initially would be the patient positioning, because this is again a different for a rectal surgery, because we have encountered many times where even a slight mistake in the positioning, the patient can have neuropraxia or nerve injuries can happen easily, and maintaining the sterility in such a position, and not, just like she pointed out, not mixing the instruments between the perineal part and the abdominal part is also a very important aspect. And the second important thing is the pelvic surgery is a very deep surgery again, so we all need long instruments, long contours, everything. And recently we encountered a case where it was a tall, obese and male patient who had a very narrow pelvis, so the contour stapler couldn't go inside at all. So just like she told, I'll go to the Johnson & Johnson company now and I will ask them for different sizes of contour, because we just get only one size. So we couldn't fire that stapler. We were planning for a LAR, we had to convert it to a APR recently now.
Recently you did.
Yeah, last
LAR,
week.
making a pouch.
Yeah, so this usage of staplers and all these things is what makes this rectal surgery a bit difficult and different. And rest, I think she covered everything from my point of view.
I'm Major Rashmi, OT matron from Kamal Hospital, Kolkata. The presentation was really nice and very crisp and short. Because everybody has told that mostly the colorectal surgeries, like it is in the lithotomy positions. One of the main complication is that venous thromboembolism. The patient should have a prophylaxis, pharmacological prophylaxis done before that, as well as during the surgery, that during the positioning of the patient, it should be ensured that the patient should be both DVT stockings. DVT stocking should be intact throughout the procedure and the next recent postoperative day, in order to prevent the VT. As well as one more, it is being said that the bowel, as ma'am said, whenever we encounter any bowel leaks during the surgery, like if we are having a sigmoid colon, it is very, it is one of the main, we will encounter a rectal So once we open the gauze pieces or whatever the linens that we use, as well as the instruments that we use, it has to be, it should not be mixed up again. And always the bowel should be corrected first before the bladder. Suppose if the bladder and the bowel is having an encoder, it is always that surgeon always prefers to correct the bowel first, because in order to not to have a contamination of the bladder, in order to prevent the infection. As well as always before the closing of the anastomosis, it is always told that the anastomosis, because one of the main complication is paralytic ileus and the anastomotic leak. So the anastomotic leak is always for a prevention. The surgeon always sees the anastomosis length should be never tensed. In order to it should be doubly confirmed that there should not be any immediate inflammation of the anastomosis part. So we say that there should be an adequate length of the anastomosis in order to prevent the tensile. That's it. Thank you.
Thank you so much, everyone. Now we request Deepak ji and Pratibha ji, Arvind ji to please come up for the felicitation of our speaker and our panelist. Deepak ji, आप करेंगे डॉक्टर, मैं भूल जाता हूँ नाम ना, डॉक्टर है ना, लेफ्टिनेंट कर्नल डॉक्टर अमित कुमार सिंह जी, प्लीज. दीपक जी हाँ आगे थोड़ा सा चले जाइए. मदन ये यूनिफॉर्म का असर है ना थोड़ा. नहीं चलो. नेक्स्ट वेट वैष्णवी भारती ना, वैष्णवी भारती. As a panelist we had Major Rashmi. Arvind ji, please. Dr. Vignesh. आप सुने लीजिए. दीपक जी आप दो. So as we approach the conclusion of our enlightening and productive conference, it is time to acknowledge and express our gratitude to who have worked tirelessly behind the scene to make this conference a grand success, to extend our heartfelt thanks and to deliver the official vote of thanks. I am honored to invite the driving force behind this conference, someone whose dedication and hard work have been truly inspirational. Please join me in welcoming Madam Nargis Bongde. Please ma'am, floor is yours.
I'm very happy that so many people have come to know my name today. So it's an honor for me. As we come to the closure of this inspiring and very enlightening conference, it is my distant pleasure to now deliver the vote of thanks. First and foremost, I would like to extend my heartfelt gratitude to our distinguished keynote speakers and panelists. Your insights and expertise, engaging discussions have provided us with a wealth of knowledge, certainly sparked an ideas and perspectives. My special thanks goes to HOD GI Surgery Dr. Sujoy Paul and Professor Dr. Nihar Ranjan Dash. Sir, thank you for investing your extremely valuable time for us. Sir, it was not possible without your guidance. I would also like to show my gratitude to the Deputy Nursing Superintendent, our Chief Nursing Officer, Nanki ma'am, and all GI residents and the faculty for their timely help to to start this conference. Thank you, my whole dedicated organizing team. Without your support, it was not possible. I wanted to mention their name, but we have a long list, so I would like to give a loud shout out. I would also like to, I forgot your name, I also would like to Army faculty and the nursing staff, all the majors, 3 sitting here. So give them a huge round of applause for their contribution and very knowledgeable contribution in this discussions. And rest, all the audience, all the attendees, you all have a patient listening today. So it was, I think you learned so many things, and in future we feel like that we will again organize such program. And this was a great opportunity by Dr. Dash given to us, and this is the first time that we have organized this conference in collaboration with the GI faculty department. So thank you very much once again, Dr. Dash, Dr. Sujay, all the residents and the nursing staff who made it possible. Thank you very much. So we have a high tea here now. So whenever you leave, please take your mementos from the counter, and we will give your certificates little later on. We will deliver it. There is some problem, so we will definitely deliver to you at your places. And जो भी अपने पास आस-पास हैं, they can come and collect it from us. And next, I would like to tell you that we have got a 5 hours DNCR. 5 hours which will be given to you. So thank you very much. Have a cup of tea and then leave.
Before we proceed to high tea, let's take a feedback from the participant side. Do we have a mic? Madan, can we have a mic for participants just to take feedback from them there? Mic. थोड़ा ले लेते हैं feedback ले लेते हैं फिर इनको थोड़ा
We are giving you mic, please.
There is a one senior nursing officer from NI cell or infection control. Please share your experience, please. Hanj mein. And we have one more nursing officer from neurosurgery OT. She was very active. So उनका भी लेना चाहिए ना feedback तो. Check. Thank you. Our next part, ma'am, please share some words. Hello. Mike.
Hello. Yeah, I'm coming from Neuro-OT. As today's session is very good and every topic is very interesting. And I think there is some point I have to bring back to my OT, and then I learned so many things. And then apart from learning, I think some of the procedures or some of the what we do is I feel like that we still need to improve. So I feel like that today session is not about criticizing, it's about how we improve ourselves in future, like what we are doing today. So everything like being a scrub nurse or being a circulatory nurse, the thing is, right, today maybe we are doing something and maybe tomorrow there will be another challenging situation. So the thing is we need to improve every day by day what we are doing. So what the important thing in our mind should be, what we should be focused is that what we are doing today is that how can I improve tomorrow? Like in one step by one step, then every day we can improve ourselves. Thank you.
Thank you, ma'am. So we have few participants from Army Hospital. Well, actually, you have spent a lot of time, if we compared with sir wala time. Sir to aaye hain aur
Actually, this is the first time I'm attending such a conference. That is, I've never attended the nursing CME conference, ma'am. I can't be dishonest on that. But one thing is definite, that even I've attended a small part of this conference, but I've seen the amount of knowledge that people are trying to gather for such conferences, and they are going to gain from it. It will be huge. And this is just the starting. There will be some, I would say, ki more things are required, definitely, because there is always chance of improvement.
Right, sir.
But जिस चीज़ से आप लोगों ने start किया हुआ है, I'm sure that you'll multiply every time that it is going to happen. And the topics that have been selected, they are actually very, very important, and they are very relevant today. And these are actually difficult topics, and they're in every way, for the surgeon also, for the nursing staff also. So I'm sure this conference will move ahead with leaps and bounds. Thank you so much.
Thanks. Navneet.
Well, as sir said that this is a first nursing this CME experience, right?
In my 12 years.
Yeah, in your 12 years and in my first life years, right? So this is very good step that Ma'am Nargis has taken. It's actually all credit goes to her.
Exactly.
Yeah, that's
just because of her face value.
Yes. Yeah, because she has been discussing this thing since months, not just months, I think it's been years, ma'am, right?
And more than 30 years, right?
Yeah, more than that you
my age is 36.
Yeah.
36, 7.
I joined OT in 88.
88, yeah, that's very huge.
So I was born in 86.
So
we can take some positive outcomes from this. We have a nursing officer from neuro surgery, so we can convince our faculty, senior faculty to समझे नहीं हम ऐड हो सकते हैं ना उनके collab कर सकते हैं उनके साथ में.
Yes.
So मैडम ने तो एक एग्जांपल सेट कर दिया. Now it is a challenge for us कि हम जहाँ हैं वहाँ से भी कुछ गेन करवाएं, नहीं? इसलिए इसको emphasize करने की जरूरत है.
Exactly. So overall it was very great experience for me.
अदरवाइज सेपरेट होती रहती है, नर्सिंग की अलग होती है, डॉक्टर्स की अलग होती है. दिस इज द फर्स्ट टाइम आई थिंक मैं 12 इयर्स में देख रहा हूँ कि जिसमें डॉक्टर्स का अलग चल रहा है, नर्सेस का अलग चल रहा है. नहीं, दिस इज समथिंग वेयर वी शुड फील प्राउड, एंड नरगिस मैम को उसका क्रेडिट देना चाहिए. नहीं, ये आपके कारण संभव हो पाया. ठीक है, थैंक यू. कोई और जी? प्लीज प्लीज मैम.
Hello all. So I have done my graduation from Army College of Nursing, and I have the honor to work both in not to work, I have studied in Army College, and I'm now working as a nursing officer in AIMS. So I would like to suggest to the AIMS organization that there should be more collaboration between Army and AIMS, so that we can exchange both of our respective practices, as well as there should be international collaboration, as I've also done one of those international collaboration. So Indian nurses should not be lag behind in any way, in any sort of upcoming advancement in nursing or medical field. Thank you.
Your ideas is very good, but we are not actually official to comment on this. So we have CNO, we have director, we have MS to answer this, but your idea is absolutely brilliant. We also want the same. चलो इसमें कुछ ज़्यादा हम बोलेंगे नहीं. कोई और? Anybody else? ठीक है, करते हैं. चलो एक ग्रुप फोटो कर ले. हाँ, चलिए आ जाइए ग्रुप फोटो के लिए. वीडियो जो देख रहे हैं एक बार उनसे रिक्वेस्ट है कि आप एक ग्रुप फोटो के लिए एक फ्रेम आप प्लीज बनाइए. आगे की तरफ आ जाइए, पूरा स्क्रीन की तरफ चले जाइए. आप नरगिस मैम आप प्लीज इनको आप पीछे की तरफ जाने दो ताकि फ्रेम में सभी आएंगे.
अदरवाइज वो लिमिटेड लोग आ पाएंगे। आप आगे रहिए लेकिन इनको पीछे जाने दीजिए क्योंकि वो बैठेंगे, कुछ खड़े रहेंगे। हाँ, ऐसा कुछ एक फ्रेम आ जाएगा।
जो पीछे जा रहे हैं एक बार आ जाइए फोटो के लिए।
वो हमारे ही है, कहीं नहीं जाएंगे। मोमेंटो हमारी है, वो जो मग्स है वो हमारी है, कहीं नहीं जाएंगे। सो
आवाज आ रही है इसमें?
हाँ।
हेलो।
फ्रेम में रहोगे तभी तो कोलैबोरेशन होगा। मानसी आओ। मनीषा सुनवा रहे हैं, जल्दी आगे बैठ। चलो लास्ट है। चारों